Morning, everyone. Welcome. Welcome to this as we continue to rotate the venue of our meeting as valuability. And today we're delighted to be, even though it's preliminary charity at Sainsbury's, located on this Board hospital site. And it's an international research centre, so a very, very good place to be. And today we'll receive the third of our case updates. So let me move on to welcoming individuals. So today and this morning we're delighted actually to welcome Muda Pereira and James Sheard from My Life, My Choice, who will present the resident story today. So I'm live resident story alongside Rachel. We also welcome Darren Nelson, Case Director for Oxfordshire, who will present the case update. We also welcome Sandra Grant, who is interim Deputy CEO, who's in the Public Sector Equality Duty Award today. And we also welcome Mr. Broom, who will be joining the system as Director of Financial Improvement. So welcome, as good to have you here. And one other, Abid Irfan, our Primary Care Director. So welcome, Abid. In housekeeping, please. This is a public. This is a meeting in public, not a public meeting. So the event is being live streamed, and those tuned in virtually, so you can observe only. I don't have to ask you to do anything with the mic because apparently our voices are being picked up. But please speak as clearly as you can. Let's move on then, please. Minutes held from the meeting on 16th of January, which feels like a month ago. The minutes, as you see, continue to be presented in a streamlined format. So we try to capture all of the key information in a way that's easier to follow and to read. The meeting, the recording from the full board paper are uploaded. It goes along to the detail. So I think we've got some actions. The two actions from the January meeting are both progressing. So if there are no other questions, is everybody happy to sign this minutes off? Rachel.
Sorry, Chair. There's just one thing I've actually attention to the minutes, which is on page 3 of the minutes under the Chief Executive Director's report. We said that the draft primary care strategy was launched for consultation. I just think we need to be really careful with the language. So engagement for an ongoing dialogue with the public and stakeholders. It is not formal public consultation, which is a very different mandatory process when you're looking about considering significant permanent changes to service configuration. So I just want to be really clear, and throughout any reports relating to that draft primary care strategy, it's a engagement.
So thank you for that clarity. So this is the backwards and forwards engagement. It is not a formal consultation process. So those mentioning it in dispatches, please use the correct language. Thank you, Rachel, for that the correction.
So there's a slight typo. Let's put it on page 7, which shall Catherine pick up.
Thank you, Tim. And then moving on, can I ask, are there any declarations of interest? Our current register is attached for information and it's I would just ask your colleagues, please keep Catherine updated with any changes to that information. We know it can change. We are in a very strange situation where the nature of our board means that with partner members, there's an inherent interest in most of the answers. So if you look at, for example, item 7, the Chief Executive Director's report, well, yeah, Nick has to give that. The place update from Dan could be considered as a conflict of interest. Primary care strategy in the update at item 10. Item 11, the joint forward plan, approach to system planning. Item 13, performance and quality report. Item 14, finance report. So other than item 11, the reports are for assurance and discussion, not a decision. So that's a measure of acceptability. So the level of conflict we believe is manageable, and as the perspective of all the members is really important, and they may participate in the discussion today. In item 11, we're seeking approval of approach to updating the joint forward plan and agreement on those system goals. So these are sort of a high-level strategic decision making, if you like. So the potential conflict of interest for any of our members is pretty minimal. So all may contribute into that discussion. Today, this is a meeting in public, not a public meeting. And when possible, we're going to ask presenters to answer the questions that we've received during their segment. So we received one question by a published deadline today, and this question relates to item 10 and will be answered by Rachel and Abby during that section. And then written answers to all of the other questions will be published within 20 working days of this. So without further ado, I'd like to commence the meeting with our resident story entitled this month. So Rachel Hosler, our chief nursing officer, will present with our guests, and I'll hand over to Rachel.
Thank you, and thank you, Chair. So it's a huge privilege to introduce our story this morning. So in our audience, we've got Kudu and James, who are here from My Choice, and we're in Oxfordshire, which was really poignant for us, and the reason that we chose this story particularly today. So My Life, My Choice, our members, and Chair, you refer to the work that we do with our voluntary community and social enterprise sector. And My Life, My Choice are part of that collaborative, which is fabulous. And particularly, this group are really active in the learning disabilities and autism action group, and have written easy read versions of reports for us to be able to access and support the local community. The story today, we've got a few minutes with Kudu and his friends talking about the devastating impact of living with learning disability when you are not supported to access health and care services in the way that others of us without a learning disability might be able to. So I'm keen at this point that we hear from them, and then perhaps afterwards we can just answer some questions about some of the things that we hear from our colleagues on the video. So thank you.
We Can't Wait is a campaign to get people with a learning disability moved up health and social care waiting lists. My Life, My Choice is a charity for people with learning disabilities. It's run by people with learning disabilities also. We've been having meetings with counsellors, people in charge of the hospitals, and saying, look, this is what you need to do.
I'm on the waiting list at the moment for ENT, ears, nose and throat, because I have hearing problems with the doctor. She said at the moment there is like a 3-year waiting list.
I'm waiting for some blue dye to go down into my stomach to stop me having accidents. It makes me fed up.
We're making placards. I like making posters.
The reason people with learning disabilities should be high up on the waiting list, because when you have a disability, you're already at a disadvantage.
Everybody with learning disabilities, our lives are difficult.
They need to put people higher up the list because people are dying sooner.
I feel that the NHS and the government should really look at prioritising people with learning disabilities.
We want people with various disabilities to live longer. I think it's a campaign that we should all be proud of. We want local authorities and various health trusts to get involved in this campaign and really champion it.
Please support our campaign.
Please support the campaign.
We can't
Wait!
Thank you, Kudu. James or Kudu wants to add anything to that point?
We hope you enjoyed the video. Since it was made, we have begun work with the two hospital trusts in Oxfordshire and the Integrated Care Board. We also have national support for the campaign from Learning Disability England and other staff advocacy groups. We now hope showing this video that made everyone in the room get behind our message. To finish our campaign, it's not about jumping queues, it's about saving lives. Because when it comes to getting the treatment need, we really can't wait. Thank you for listening to me. If you have any questions, I will try to answer them.
I don't know that well. I'd like to, do you want to say a little bit about yourself, comedian, who you are and what else you do in my life?
My name is Luke. I have a learning disability. Because I was born with epilepsy as a child, so I didn't really have a get the education. So I'm happy to support our colleagues of My Life, My Choice, because I understand the difficulty and hurdles where other people who've never been in that situation don't understand it. So we need people to actually think for themselves what is actually going on, not just listen to negative stuff that's on the news.
So it's about making positive change.
Yes.
And what is special about My Life, My Choice in terms of who's in charge, who are the trustees?
Yeah, they have several trustees like Paul Scarlett.
That's true. And he is indeed a very good leader. But what's unique about Paul and AD and all of the other trustees, what do they all have?
Yeah, we all have learning disabilities. And we lead the discussions, and then James helps us present it in a way that everybody understands, so nobody gets excluded.
And so the campaign works, it's part of a particular group of My Life, My Choice. Did you want to talk a little bit about that?
Yeah, we also have a champions group. So with champions groups, we decide what subjects we want to talk about, and then James supports us. So one of the things we talked about is getting a video made. So we all had a discussion, because obviously to make a video it needs funding, and also because it's a charity, they have to spend money wisely. So we all had to have a discussion and agree what's going to be put in the video and present in a way that everybody understands it, so nobody gets excluded. So it's simple and basic for anybody to understand, including people with disabilities.
And just to take a step back, with We Can't Wait, can you remember the reasons the champions particularly wanted to do this campaign?
Yeah, the reason why we wanted to do this campaign, because we realised when people with disabilities are in hospital, they just get putting on waiting lists, which is not good enough. They need to be higher up the chain, because obviously they're already at a disadvantage by having disability through no fault of their own. So they need extra help and support, because without that, their lives are just going to be more affected. So we need, that's why we need this campaign to affect positive change.
And do you remember how COVID affected all of that?
Yeah, because a lot of people with disabilities died before their time during the COVID pandemic, which is not acceptable.
And what does it do to waiting lists?
The waiting list went up even further, so it's more chaotic than ever now in hospitals.
But as you say, we have a very positive approach.
Yeah, we have a positive approach. Yeah.
What sort of, do you remember some of the things that I don't mind because you're not cross-all meetings where you've been very big for spreading their legs and not seeing too much.
Yeah.
Some of the things that we worked with Dan on, for example, in Oxfordshire, some of the sort of discussions we had with Dan and the draft. Do you remember sort of some of the things that that feeling?
Yeah, one of the things is getting the people who run hospitals to support our campaign and support people with people with disabilities when they come to the hospital.
And look at perhaps ways that the system can do that a little bit more jointly. So we've had meetings across Oxford Health, Oxford University Hospitals, and with down there too. And you're right to talk a little bit about what I went to, some of the things I've been doing with Dorney and then
Yep.
so a couple of our other champions have been working on. So Dorney, one of our champions, went to a meeting about NHS flagging for people with a learning disability. We've been talking about how the different systems can talk to one another better when people are learning on waiting lists. And Dorney and another champion, AD, they've been working on a sort of easy read process to share with hospital trusts that we've already shared with Dan, that we could potentially share as a kind of good practice example as well. Okay. Have I missed anything important, really?
We have been teaching other people how to break easy read as well, because not everybody knows how to break it in an easy read format, because if they don't know how to break it, then how can they help in hospitals? So, because not all hospitals do it.
Yeah, we absolutely have these research. Oh, and one of the two other important things I missed is that my name is James. I'm a patient protection coordinator, and I'm dressed like this because my bike colours are really, and I should not have seen. Have I missed anything else for you?
No, I don't think so.
Okay, do you think any questions?
Is there any questions?
Yes.
Hi, Maria and James. Thanks very much for going in. Great video. So thanks a lot on that. You mentioned in the video that there are two hospital trusts already around the country that prioritise people with learning difficulties, disabilities. Which ones are they? Do you know?
Can you remember who did, or do you want me happy for me to say this one?
Yeah, I think.
Okay, so there was a trial in Bristol, North Somerset, and South Gloucestershire. And then the other one was Alderdale and Hospital.
And have you seen, has that gone down well? I assume that's been a success and you've seen some benefits?
Definitely, we got quite a lot of information back from Huddersfield and Alderdale. We got a small bit of information back from the one in the southwest. We have tried sitting with them for a bit more, but yes, certainly Huddersfield and Alderdale, and I think Oxford University Hospital, they've been in touch with them around some of the work they're doing.
Thanks, nice. Thank you.
No problem.
Rachel.
Hello, I'm Rachel Shimon. I'm the Chief Executive in Buckinghamshire Council. Good to see you both. It's not a question, it's just three comments really. So the first thing I wanted to say is that I think We Can't Wait is a brilliant title for a campaign. It just absolutely nails it.
Yeah.
It's a really shocking statistic, isn't it, that 6 out of 10 people who are learning disabled die before their 65th birthday, and as a country we should be collectively ashamed of that and be doing something about it. So all power to you. And then the final thing I just wanted to say is that I wish the whole world was easy read, because I think easy read makes it easier for all of us actually to understand some really complicated issues. So, you know, I'm a massive champion of easy read, and it was really fantastic to listen to you. Thank you.
Thank you, Rachel. Thank you so much for coming, for bringing alive the campaign, for making us understand. And that's true inclusivity. And we really appreciate your time. So thank you. Thank you very much. Thank you. CARES report to give an indication as to work going on sort of nationally and to talk about the wider system. You'll see from its report, which is very full, there's plenty enough to be going on, but we can spill it. So I think for my report, I'm hoping everybody's had a chance to read it. I would just like to draw attention to a correction on item 7, where I talk about the voluntary community and social enterprise sector. It turns out that Stephen Barnett attends both the system people, not the Population Health Board subcommittee, but actually what makes the system development meeting. So there are still 2 subcommittees that he attends, but it's not Population Health. I think for me, I would just pick out, if I might, the events that we held on Friday. So we recently held an event for about 40 colleagues. And the event was part of our trying to engage the non-executives and all of us into the wider system. We invited chairs, CEOs, lead governors, and non-exec directors from the provider trusts. And we have an attendance of about 40. And what we talked about was system governance. So the difference between what we're doing now, which is looking at individual provider trusts and their accountabilities within that, and exploring how, as part of the system, as we all are now, how one starts to think about the system in from governance terms within the body of their own individual meetings. It was great to me. The biggest feedback that we got actually, having had a presentation from Andrew of the GGI, was the fact that people had got together at a time when they hadn't even met before. So this is a sort of a symptom, I think, if you like, of this huge, complex, sprawling system. And it is absolutely incumbent upon the ICB to create convening opportunities for people to get together. The conversations that were held between non-execs of different provider trusts, chairs speaking to lead governors, the ICB speaking to lead governors, we don't get access to these people on a daily basis. I left the meeting feeling really pleased that we'd done it, promising that this system would continue with that sort of convening with all different parts of the system. And actually there was a big call. I had a colleague, a NED colleague from SCAS, who said, where is the PP representation? And I say that because I think it's really important. More and more people are calling for primary care representation in every single space that we move in now. So I think we'll take heed of that, George, and just remember that. Perhaps we need to start considering primary care as a provider in the same way, so that we absolutely introduce those teams. So I think from my point of view, the event went well. It will continue. It's a good getting together. Just yet we've much work to do. I did some RACI exercises where we explored accountability and responsibility against national, sort of regional ICB provider. It was really interesting. What was interesting was the interaction between those people rather than the result of the exercise. So we will continue with our convenience. But on that note, can I ask, please, are there any questions that anybody wants to ask me, having read through the feedback? I will continue to update as we go through. Mark.
Just a comment, thanks. I thought your report of the NHS England networks, paragraphs 10 to 12, was really interesting. Yes. Because to me that illustrates the dissonance of conversation and priority between NHSE discourse about productivity and what we've just heard about changing lives, about looking at marginalisation, about long-term population health. And just thought that clash between paragraph 10, NHSE conversation, productivity and the acute sector, and paragraph 12, the public are interested in coordination of care and continuity of care. These are parallel conversations. So that I think that's really encapsulates our struggle about the long term and the short term and trying to move to that long term conversation where productivity has a very different meaning, with the book standards, which are important. I just so few words that really
yes, there is that tension, but this is exactly why these systems, and this is why we're here to bridge that gap. So whilst there's a tension nationally, we mustn't forget what we need to do, which is why it's so important to be grounded in reality, having the resident story that we in this meeting and his us into that reality. Do you want to bring something?
I've seen it, it's on the comment section on Friday afternoon. Yeah, and I've shared all the reflections here. I certainly found it a very energising way to finish what would be a somewhat challenging week. And I suppose one of the things I took away from it was and you know that go involved the leader, which is to deliver hope, which perhaps we should not forget given the scale of the challenges we are facing, some of which I'll touch on in my report.
And just also, once you submit the meeting, so that people not as close to this, perhaps anything in the room is, I'd just like to echo both your thoughts on the event on Friday, which was really, really positive. It was great that as a system we were coming together at that level and meeting each other and having some formal and informal chats. I thought Nick's comment in the middle of the session was really genuinely inspiring, and then there was murmurings at the table I was sitting at, which is to say how great it was to hear such positive hope for the future, accepting it's in the children, but I think it was genuinely quite inspiring. So I've just said it was a great event and we should do more of it.
Okay, if there's no further questions from me, I'll move on because I've been really got a body of work that
Yes.
you'd like to share with us.
Yes, I'm not entirely sure that my chief will be as inspiring as I said on Friday afternoon, Tim, but we can see. Can I just begin by saying I'm very pleased that we're holding this board meeting in the Prince of Wales International Centre on the Woodland Hospital site. It's a site very close to my heart, given my previous role as Chief Executive of Oxford Health. And just so colleagues are aware, Oxford Health have very ambitious plans to redevelop this site to build a new state-of-the-art psychiatric inpatient unit that will be linked to a research facility, and then they convert the old hospital into a postgraduate college at the University of Oxford. So we create a brain health campus, which probably would be as good as any facility requirement in the world. So I'm pleased that those plans are progressing, and I'm sure the ICB in due course looks forward to an update from our Oxford Health colleagues regarding the plans. I'll take my report as read. A couple of things I wanted to highlight before I'll hand over to Rachel, our Chief Nurse, to provide some more detail in relation to the policy items. Firstly, for the national focus in terms of performance, very much continued in relation to emergency department performance and hitting the 4-hour target, waiting times for patients being treated for cancer of one kind or another, and patients who've been on waiting lists for 78 weeks. So those are 3 areas that we as a system are focused on between now and year end. We have an assurance call with the regional team tomorrow. Performance in some of these areas has not been quite what we'd like it to be. Very pleased that our ED performance across the system, however, does appear to have improved significantly over the last week. We're currently in the midst of the annual planning cycle. We're due to submit our draft system submission on Thursday this week. It's fair to say it's a challenging period given the financial and operational pressures. We had a useful call with the system partners yesterday. Obviously, we'll keep all the colleagues updated regarding the planning process, which will extend for a number of weeks. The system's financial position continues to be a cause of concern and therefore under scrutiny from both regional and national colleagues. With that in mind, I'm very pleased that Ursula has joined the system as of yesterday as our Financial Improvement Director. He brings with him a wealth of highly relevant experience, and I'm sure will be a very strong addition to the system's team. We're going to touch on the primary care strategy in a couple of minutes, and Rachel, our Chief Medical Officer, will provide updates in relation to that. This one's flagged to be a very important system workshop tomorrow in Reading at the football stadium. For about 170 colleagues from across the system attending, and very much looking forward to endeavouring to chair that event, which will, I think, be an important step in the development of our strategy. A few things just to say in relation to our people, I mean those colleagues who work in the Integrated Care Board as an organisation. Firstly, the change programme redesign process is ongoing. We look to develop our future operating model, and conversations are now advancing with system partners regarding those functions which perhaps can be transferred or delegated either to our developing place-based partnerships or indeed our private collaboratives. I'm very pleased to report that through the leadership of one of our place-based directors, we had an incredibly energising leadership forum towards the end of February at council offices in Aylesbury, attended by about 90 of our senior staff. The theme was emotional intelligence, and the importance of that in leadership. It was one of those events I think was quite uplifting for everyone who was involved, and very grateful for the leadership that her team provided. It leaves the one thing not to mention this year's or last year's staff survey findings. Unfortunately, the survey indicated limited improvement in overall staff engagement across the ICB compared to the previous year's survey, and highlighted that there are a number of areas where we really need to focus on, and also reinforce the importance of expediting our organisational development work. I know the survey's already been discussed at our People Committee and the Staff Partnership Forum. There is much to do to ensure that our organisation is a truly inclusive place to work, and one which enables people to fulfil their potential. It's perhaps not surprising that the survey was what it was, but that's no excuse. We should really focus on the actions that we're taking on now and ensure that they're delivered at the same pace. With that in mind, I think it's a positive development that we have now appointed 3 new Freedom to Speak Up guardians from across the organisation. Their names are referenced in the report. I'd like to just thank Sailor, Alison and Zoe for being the heads of preparing to take on this important role, which I think has an important bearing on how we develop the organisation and ensure that people feel able to speak out and speak up if they have any concerns. So I look forward to working with them and we'll meet with them on a regular basis. Finally, before I hand over to Rachel, just to highlight the work in progress in relation to the ICB hosting the Thames Valley Cancer Alliance. The Alliance is an important part of the NHS's infrastructure, supporting the delivery of cancer services, not just across the board, but also across the Great Western Hospital area around Swindon. So we'll update board colleagues in relation to that process. Likely to involve the transfer of about 30 members of staff who are currently hosted by the regional team for NHS. Rachel, I'll hand over to you just for an update on government practice.
Thank you, Nick. So, your board's attention to, so firstly, as reported in your report, we received the finding letter summarising the findings of our joint targeted area inspection into our multi-agency safeguarding hub services in Buckinghamshire. And I think it's fair to say that leaders across the board were really proud of the findings from the inspectors that came in to judge our services, and that was both from the TPC, Ofsted and His Majesty's Inspectorate of Fire and Police Rescue Services. So a really positive inspection. Clearly there's ongoing work for us to do and actions already in place across the county and with all our partners to respond to areas where they've asked us to take further action. You'll see we've summarised 3 CQC findings. So the first is the National Maternity Survey was published into feedback from women and birthing partners who experience and services across the county. And I've summarised in the report what those findings were, and what we found within our area was consistent in improving maternity and neonatal services for our community. And it would be remiss of me not to draw out the findings of the inspections that took place into the maternity services, both at Lawbox and the Horton Oxford University Hospitals Trust. And as we've reported previously, that's part of the National Inspection Programme that's been underway. And the Horton service was inspected and rated as requires improvement, noticing some areas of good practice, but clearly ongoing work for the team to be taking, and we will continue to stick in there. But delighted to be able to share the ratings from the Royal Arts, but they were judged as being good and some really good examples of outstanding practice at the Royal Arts Hospital. Just a couple of other things that we will have all been aware of: the intention to implement Martha's Rule following the death of Martha, and we've been able to share on the learning from the Royal Arts, so they have their service, and looking at how we can roll the principles around that for concern for families and patients where they need additional support and input, and that will continue to be implemented. And as reported previously, we are working with our trusts on implementing the recommendations that came out from the initial inquiry into the David Fuller issues around watery services, and will continue to support them going forward. And what's not in what I just wanted to reference, measles. So again, we touched on that in regard to infection prevention and control. We are, like all other systems across the country, now experiencing cases of measles across our system, and clearly our ambition is to increase the uptake of vaccinations and really promoting the benefits of vaccinations for all ages, but particularly for our children and young people, in response to the increase in cases that we are starting to see locally within our income.
That's it for me. Open questions.
So, any thoughts or questions? You can see that we're under financial stress, I would suggest, but it's really important. We've got work to do, so we have to manage that with everything else. So those are plans to be struck. And you can see from the fullness of Nick's report the sheer amount of work, endeavours, and areas to concentrate on. So, colleagues, are there any thoughts or questions for this stage?
Thank you. So three areas. So on the Thames Valley Cancer Alliance transfer of staff from NHS England, as part of the NHS overhead budget reductions, will those 13 people count towards that reduction is in question? On the rescheduled activity as a consequence of industrial action, I just wonder if you could say whether there was any national assessment being undertaken of impact in terms of either health outcomes or KPIs in relation to weights, because of that sort of bulge in the system. And then I suppose more locally, what's our sense of whether or not there's a recognition from the NHS that there will be an impact on weights and potentially some long-term health issues? Thank you.
I'll look to Matthew to pick up the Thames Cancer Alliance question, supporting the impact on activity of industrial action.
Yeah, so for the Thames Valley Cancer Alliance, so as always, these things tag complex, but in terms of the legal question, Rachel, so I think the reduction in headcount from people employed by NHS England transferred to us will be part of their headcount reduction target for NHS England. But just to reassure board members that the transfer of staff into our organisation will be funded by ring-fence money. So I think that answers that particular question. Rachel, on the industrial action, I think it's a good point. So I'm not explicitly aware of any national review at the moment to assess the impact of industrial action. That may well be in the pipeline as things settle down. But that may well weigh perhaps until industrial action in the longer risk to take a comprehensive view on the impact. We're aware and have highlighted the board previously the impact it's had on both activity and wait times, and you'll get a sense of that in the performance report later, where effectively there's been a national recognition that the desire to remove all waste post 65 weeks has been replaced by a drive to focus on 7-day weeks, and that's directly a correlation to the impact of industrial action, in my view, and there is a recognition there. I know that Rachel, of course, and the team have been keeping an eye on farm and impact for industrial action in terms of specifics, I think. And while there have been few specifics, the question about more generic impact is the one we're getting at, and I think that will require further work, probably at a regional and national level.
Thanks. I think your question as well, Rachel, highlights the importance of the initiative we've heard about, the We Can't Wait initiative. It's important that the the impact of digital actions not serve to exacerbate existing health inequalities. And we need to do what we can to make sure that we manage those waiting lists effectively and ensure that there's no further discrimination.
That NHS England and the pressures on us as a system. Can you articulate there? Ask people.
Right, so that's okay. So the recognition is probably where I referred to a realisation that we wouldn't achieve the 65-week target. That is a recognition for extending COVID. And also we should acknowledge actually additional funding has come into the system to acknowledge the financial impact of industrial action.
Thank you, Rachel. Right, Mark. Margaret and the name. No, please.
Thanks for the report. And it's really encouraging to see the really good results from the safeguarding and maternity review reports. It's really there's a lot of work behind those. Question on Martha's rule, Rachel, on the state of readiness of the trust involved, particularly in 10 days' time. Are you assured that we are? What's the state of readiness? Are we fully ready? You know, the voters and the teams ready to provide that service?
So there's a phasing. So there's a trust that going forward with the first phasing of implementation. All of our acute and specialist trusts have access to critical care outreach services, and how that is done is variable across each of the trusts, but we're working with them ahead of any implementation at scale.
So we're confident that those first acute specialist trusts are ready to, with the service and resource that's required.
We don't have, we none of our trusts are part of the first phase of the first one. Yes, but that's not to say that we haven't already got, and as I mentioned, what's coming, we've already got a really robust concern service in Royal Berks. BHP have critical care outreach, as does Oxford University Hospital, but the way they provide it is slightly different.
Thanks, Chair. Just with reference to the stats survey as well, I mean, I know people committees and that work on this. It would be, I think, useful to identify any areas where there's a role that the board or non-execs and execs can play a kind of improvement role in the kind of actions that will no doubt stem from those discussions going forward. So if there's an opportunity to just revisit that so that we've got a tangible that we can say, okay, you know, there's a pattern, there's an issue, there's something that we can contribute there. So it'd be great for us to come back to it so that we've got an opportunity to contribute and participate.
That's really welcome that, David. Thank you. Thank you. We all have a role to play, don't we, in ensuring that the ICB is a great place to work. And we all are leaders within the organisation. What we say, what we do, what we don't say, what we don't do, impacts significantly on the overall organisational culture. So I think that's something I would value everyone to bear in the back of their minds. And whenever you have an interaction with one of our teams, one of our colleagues, it will have some bearing on what it feels like to work involved. And we want it to be a very positive experience, to be able to retain our best people. We want people to enjoy working in the organisation. Because I often say, happy cows produce more milk. People perform better, you know, they're more productive, you know, and it's important we get it right.
Questions with thoughts at this point? No, shall we move on then? Thank you. Very happy now to move on to the Oxford case update. This is our third actually geographical-based review. And just to remind everyone, House Watch and the SCE are members of the case. And it's really important, really glad to welcome you, Dan, today. And just so that we can understand how that partnership, how it's going, how the collaboration is actually working. Are some parties being able to cede a little bit of power so that the system overview and objectives can be achieved? Where are you in your progress? It'll be very good to hear.
Thanks very much, and thanks very much for inviting me to do that. And just before so I'm Dan Leveson, Place Director for Oxfordshire. And I suppose just before I start, I was really thrilled to see that we had My Life, My Choice here an organisation that I think we can learn a huge amount from. Just by that, I was just saying to James, I've not had a meeting where people with learning disability have not been in the room, and they are designing some of the projects that we'll do next year with them for people with learning disabilities. To Rachel's point, a particularly vulnerable group of people. So yeah, it was great to see them here. I suppose what I'll do is I'll do about 4 or 5 minutes of kind of intro. You've seen the pack, and then happy to have a conversation about place-based partnerships. So Oxfordshire, as you've seen in the pack, we're about 700,000 population, largely rural, with some significant areas of deprivation. So we do have some of the most deprived wards in the country, particularly in Oxford City and in Banbury, and one of the wards in Abingdon. The other thing that we do have, like a lot of our counties, I think, is some of the hidden deprivation that we're not particularly well equipped to understand or respond to at the moment, is the rural deprivation. So that's some of the stuff that we grapple with as a system, as a place. I think there's a lot of elements that give us a good foundation for success. The fact that we've had a long-standing Section 75 agreement between commissioners and the local authority, the fact that we have a large pooled budget particularly for adults of working age, and for some of the health inequalities in our Better Care Fund, so a lot of our urgent emergency care services. We have a joint commissioning team that's been around for a few years now and serves across Start Well, Live Well and Age Well. We have very well experienced providers, particularly of collaboration. So Oxford Health is in its 8th year of an outcomes-based contract with the voluntary sector partners for adults. They also deliver large provider collaboratives for the specialist mental health services, and there's a memorandum, an MOU, a memorandum of understanding between Oxford Health and OUH to work together. So there is a lot of good ingredients, I think, for us to build on. Our role, what we agreed as a place-based partnership, so we've been meeting regularly for, I guess, 15 months now. It's well represented. We actually have Health Watch in our partnership. We also have voluntary community sector represented, as well as general practice from across the county, public health, and the local authorities alongside our NHS partners. Our role primarily, what we've agreed is we identify populations that are going to benefit from better joined up care. So our particular populations are children and young people with special educational needs. So that's in one of our priorities as we progress, and then getting better at integrating for children and families. Because actually, if you look at 0 to 5 school readiness in most of our counties, actually, we perform worse than national average. And if we think about the next 10, 15 years and what Michael Marmot has said about prevention, that's probably a population that we need to really support better. Adult and older adult mental health, so joining up our services into the second phase of our mental health outcomes-based contract. So the next iteration of that. People with urgent care needs, where we probably had the most success over the last 12 to 14 months. Which is shown in the slides. And then our new area of work, where we're really working much more on prevention, much more to reduce health inequalities, and supporting voluntary community sector partners. So particular focus on the 10 most deprived wards, developing projects that will make the biggest difference to those people living in those wards. We have a big programme of activity working across local authorities and voluntary sector, so with our city and district colleagues, as well as county council. So that's very exciting. What we've done as a partnership is we measured, we have a maturity matrix. So we've got 10 indicators of healthy systems that we measure ourselves against. And we've done 2 versions of that. The initial survey that we did, we self-assessed as emerging. We self-assessed about 2 months ago, and it's moved on. We're about 50% developing. So there are green shoots, I think, for a partnership. And then I suppose finally, like I said, moving into the next, our next financial year, SEND is going to be a big area of work for us. We had a recent Department for Education improvement, and we have a priority action plan and a whole system improvement program underway. I co-chaired the delivery group for that with the Director of Children's Services. Rachel and I sit on the improvement board for the system. We have substantial or significant work to do with the urgent care system. So essentially working with our Better Care Fund and the additional discharge funding that we have in the system alongside the ICB urgent care allocations, finding ways of building on the success of our two or three key areas, really the urgent care centres, so primary care led urgent care centres in the north and the city that have had a big impact, particularly for our emergency departments and for primary care, so diverting people with same day needs into those services. Developing our integrated neighbourhood teams. We have about 2 or 3 really good emerging examples of the integrated neighbourhood teams, particularly Bicester, Banbury and in the city. The work that we're doing around our virtual wards, so supporting really acutely ill people, and that's actually a joined up service with Oxford Health and Oxford University Hospitals, which is great. And then I think finally and importantly, working with our local authorities who have done an amazing job really engaging the market to deliver much more care in people's homes. So we've increased the amount of hours that we deliver care in people's homes. We're able to get people back home more frequently and sooner. So we've managed to reduce delays in discharges and things like that. So I think in summary, the emphasis for us is on partnership working, it is on relationships. I think we underestimate the value and the importance of having those relationships, and we really committed to being aware of that, and carrying on with the work that we're doing, and really trying to find ways of putting our organisational, working beyond our organisational boundaries, which particularly, and I've referenced it in our risks, I think particularly as we head into what is going to be another challenging year with regulatory pressure and financial pressure, we need to continue to be confident that we're doing the best for our populations and trying to find ways of delivering the best value care. So the collective impact of our resources to deliver the outcomes for those populations. I'll pause there and open for questions.
Thank you. Thank you very much.
I think just to build on what I think we'll have a discussion about the board that have many challenges, but I think it's really important that we hold this space at Playfair and some of the work that all the place directors and their teams do. But as Dan said, we have the whole integration and the platform space can be more important as the financial constraints grow. And you can see in some of the work that Dan does, the relationship is built up with the voluntary sector across Oxfordshire. The Oxford Move Together partnership that is holding the space and prevention. It's hard and it's difficult, and it will be even more challenging as we get to fight. But I think it just emphasises the importance of the place partnership model matrix.
As well said, it's the only place where we talk about prevention, so it's highly valuable, and anything the ICB can do to continue you on that path of kind of improvement and impacts down, you've got to keep asking. Right, thank you. Any questions? I think I saw 2 hands over here. Should we start with Sakim and then George?
Thank you. Really insightful one. Just had a question on the areas of deprivation that you highlighted and how we're going to ensure they're protected or that they don't suffer while we deal with our financial payments.
That's a good question. So there is a huge emphasis on those areas of deprivation. So ANSAP, our Director of Public Health, I think 3 reports, so they do their annual reports every year. His report was about those areas of deprivation. So we really began to look at those areas in detail, and we built community profiles for each of the 10 wards. So we do emphasise that. We've got particular projects through the funding that we have for the health inequality. So we're doing something called Well Together, working with the Voluntary Alliance in Oxfordshire, and we've built up a programme of work where they've developed in those communities specific projects that build on the assets. So for instance, Blackbird Leys has it has a good health and wellbeing centre, so what we call a leisure centre really. It has a well-established primary care network and things like that. So we're working with local anchor organisations in there to develop those services. I think so we're doing what we can to continue to support them. I think it can't be underestimated though, our structural and systemic stuff that kind of probably maintains this inequality that we've got to keep working on. So things like the campaign where if we recognise deprivation, if we recognise learning disability as another risk factor, how do we disproportionately prioritise those populations? Again, I think I can't underestimate the challenge, the equal challenges that we have in rural areas where there is a danger that we focus too much on those deprived areas, and then we create a real tension between populations. So we have to work really carefully on it. But I suppose the answer is we do what we can with those populations. We support them. There's a lot of work going on, but it is systemic and structural, so it's going to take a long time. And it's to Matthew's point. Part of me is we have to hold our nerve. We have to be in this for the long run. I think one more year of health inequalities funding is not enough. You know, this is 10, 15 years worth of work. So yeah, I work with the public health a lot on that.
Like Sim mentioned earlier about the real kind of need for different practice to feel system part, and I think being frank, colleagues in Oxfordshire haven't felt that with losing the presence of the world famous tertiary trusts. There wasn't much mention in here about how you integrate general practice into the place-based leadership.
Yeah.
Just maybe a bit about
Yeah.
that. And given that our population, when we ask them, do say access to general practice is a big priority for them, with the handing back for contracts on Totley last year, actually, how are you making sure that these priorities support the clinical practice infrastructure and therefore patient access to service?
Yeah, thanks, George, for that challenging question. So from the beginning, if I didn't say it, so on our place-based partnership, we have 3 GPs. So we're represented North, City and South. So from the beginning, they have a voice at the table, which I think they haven't previously necessarily felt like they have. What that's manifested itself in for next financial year is actually we found a way of funding. So we have the ICB urgent care funding stuff, and we are supporting the development of those urgent care centres in the North and the City, which are run by the Federation in both North and City. We're also supporting the development of the integrated neighbourhood teams. Both of those things, I think, George, will to some extent manage some of the demand. So in theory, our integrated neighbourhood teams will support people with the most complex needs. So we'll have an integrated team around, when you know this, right, with people with frailty living in deprived areas and whatever else. On top of that, the urgent care centres, primary care is able to send people. So people like me, who every now and again will need something, I shouldn't be the first person on a Monday that you get to see, right? So I should be able to direct there. And then on access and things like that, it's some of this is about the engagement that we have with local authorities. And I've said to Rachel and others, there's not a public meeting that I go to where I'm not challenged about 3 things really: access to my GP, and it's actually I can never see my GP, GP estate and dentists. We've got to work as a system to find solutions for it, and it's not going to be a place-based partnership. We can focus on populations that will alleviate some of the pressure, but that's the best we can do.
Yeah, thanks, Dan. Really interesting. I was really encouraged by the UEC impact example you gave on page 34. The numbers going in the right direction with the home first and replacing hospital, acute beds and so on. I just wondered if beyond that, I'm sure there's a lot more beyond that.
Yeah.
Do you throw that out to partners and find that there's an impact on ambulance resourcing and handover delays, because the whole system connection, you've mentioned 3 things in here.
Yeah, so and like you say, those are slides taken from about a 40-page highlight report. So yeah, we've got a full, and I think that's been the defining difference for us in the urgent care space over the last 12 to 18 months, is the fact that we have a delivery group that meets every fortnight, that has voluntary sector, it has ambulance service, it has the community mental health provider, it has everyone in the room pulling in the same direction. We have our local authority colleagues involved in that. So that's every fortnight. Then every month we have the urgent care delivery board, plus we have an escalation call at 8 o'clock on every Friday, where we're talking about unblocking some of the issues that we've got. So, and it's like I said at the beginning, the defining difference is we have regular, honest, open, transparent conversations and challenging conversations about how are we moving forward, how are we removing blocks, whereas before I think we maybe would have sat in our organisational silos and said, well, how can I look after, protect my service? And so yeah, the for instance, ambulance handovers at the John Radcliffe thing tend to be good.
There's a really powerful story that we can share about the Boston working.
Well, it's interesting when we talk about the story, and I don't know, so again, over the last 12 months, the story that we haven't successfully narrated yet with our populations is exactly that. Our ability to support people in their homes, our ability to discharge people in their homes, so avoiding admissions or getting people home, we are doing it. I think our challenge as a system is to build confidence in that model of care across general practice, across local communities, across elected officials, and things like that. So that's really, and Sarah and I are talking about how we engage populations in exactly that model of care, because we do believe, I should say, that as a system that model is going to protect us in the future. But so it has taken us 8 years to permanently close the hospital, community hospital beds in Wantage. And I think part of it we need to learn, and that's why, again, come back to my choice, actually working with local populations on that is going to be really important. But there is good stories in there. Yeah.
So hold that space.
Yes, thank you, and thank you for the leadership we provide into the system. I was going to reference Washington Community Hospitals. I think it is a good example of how we are working more effectively as a system and how we are engaging more effectively with the local population. I know you've been intimately involved in that endeavour, so thank you for that. Two things for me. Looking at the life expectancy graph, I was really struck by Tame North. It does seem to be the place to live. It's got the highest life expectancy in the world. I'm not sure that's just skewed by a few numbers, but is there anything we need to learn from Tame? But just thinking about where we are today, and this site is the example of how the NHS is collaborating with the different University of Oxford. Is there more we can do within the Oxford system to build on the relationships we have with our two local universities?
Yeah, absolutely. Tame one, I don't know. I don't know what the answer is on Tame, but we do talk about that quite regularly at Health and Wellbeing Board. On the collaboration point, I think we could do more of it. We've got some really interesting work underway with Health Watch and Public Health and the universities around community research networks. So there's a huge, in fact, yesterday there was a all-day event just focused on community research networks and things like that. So there is the support that can give us, as well as, look, we're one of we have 2 biomedical research centres in Oxford, which I don't think anywhere outside of London has. So we do need to make more of it. I think, and again, I don't have a really good answer for it right now, Nick, but I think we do struggle to engage with the research and innovation sector. I noted it yesterday at the Community Research Network, where actually our local authorities and our universities are working much more closely, maybe because of the public health link, than we are right now. So, but I have those relationships and we can do more.
Thanks, yeah, thank you.
Thank you, Dan.
Thank you. Thanks, everyone.
Thank you, Michelle. on today are project like that over to great literacy, but just in addition to that she had one in the years. I think I've asked that we as a group of people as a board that we have access to some of the responses coming back from some of our stakeholders. I prefer reading the memory care response and the joint response as well. So I think it would be useful because I think we have two cases that the feedback is coming into. So we'll do that together. Over to you.
Thank you, Chair. And I'm going to just spend 2 minutes doing a very brief intro and reminder, then hand over to Abby to give some early stage emerging themes feedback, and then I'll take the question at the end, if that's okay. So the draft primary care strategy is a really important piece of work that will help enable our delivery of the joint board plan. We have been engaging since January across all 4 pillars. Really thorough engagement, whether that be with our place partnerships, provider boards, Health Watch, Joint Boss, or with some of our more vulnerable members of the population, for example, homeless, sex workers, travellers, drugs and alcohol, as well as professional groups and patient participation groups. Really important to say we're building on strong foundations. We know that, for example, even though access is referenced repeatedly as an issue, we benchmark well in terms of region and national in terms of access to primary care. But we know that there's variation, we know that there's shape differences in outcomes, and we know that there are workforce challenges. And that patient experience of access in both general practice and dental has declined significantly over the last 2 years. We know that there are challenges around administrative burden, recruitment and retention, and a changing demographic, so an ageing population with a quarter of the adult population having 2 or more long-term conditions. That makes our current model really unsustainable. So the strategy sets out 3 big priorities. We didn't want to have 110 priorities, none of which would be delivered, so we wanted to boil it down to 5 impact priorities. But reminding everyone that at the same time this is going on, there is the primary care access and recovery plan, which focuses on general practice since last year. So, for example, focusing interface between primary and secondary care as an example, all of those things are ongoing. And the 3 big areas, just to remind, are around how we deal with low complexity work. So 70% of work is low complexity, but it's taking up 50% of general practice time. What we want to make sure is that patients are seeing the right person to get the right care first time. And that won't always be a GP, because our GPs should be operating at the very top of their licence to be able to spend more time with patients that need it, with complex conditions, and giving continuity of care. The second bit is around integrated neighbourhood teams that have already been referenced today. So identifying those members of the population with complex physical and mental needs that would benefit from proactive personalised care, so that they don't end up in our acute providers in the emergency department, which gives a very poor experience, poor outcome, and is expensive. And then the final big sort of priority is around cardiovascular disease prevention. That is not to exclude all other aspects of prevention, but we know from the NHS long-term plan that this has the biggest impact if we get it right, reducing morbidity, mortality, and keeping people active and working. We reduce those that are having heart attacks and strokes. We can do that by managing the risk factors around diabetes, hypertension, smoking, or obesity, to name just a few. We have a big event tomorrow that's really important with system partners, stakeholders, and the voluntary sector, which Nick, Chief Executive, has already mentioned. And on that, I will hand over to Abid to give some feedback on emerging themes. So,
yeah, thank you, Rachel. Thank you, Chair. So, yes, as Rachel outlined, a significant, huge kind of depth and breadth of the engagement we've been doing. So, I just want to thank partners on this table as well for that. We've had a huge number of responses, and we're still doing the kind of analysis of that. So, we thought it'd be useful just to kind of go through some of the emerging themes. In general, the direction of the strategy and incorporation of the kind of 4 pillars of primary care generally been accepted. Certainly good feedback in saying that we've got the right number of priorities, and the priorities look like they're the right priorities. Varying comments on the level of ambition. Some comments saying that actually it's too ambitious, and others saying, are we ambitious enough? So perhaps we pitched it at the right level. Don't know. big theme coming through is around communication with patients, not only kind of implementation of the strategy, but what will things look like, pathways of care. They really want to understand. Actually, more than that, they want patients, you know, and organisations want to get involved in the kind of delivery of that and kind of developing those, for example, neighbourhood teams, and really getting stuck in. So that's come out nearly, I think, in every meeting. So a good strong comms plan and getting involved with co-production, and certainly as we've heard from the and getting the voluntary sector and other communities involved as well, because they've got that local knowledge. So I think it's important to tap into that. Kind of a feeling of that one size doesn't fit all. So we've got 3 places, different geographies, different kind of priorities. So we've got to think how we don't want to kind of railroad one big idea down to everyone. There may need to be nuances at place. So I think we need to be sensitive to that. And around access, something that kind of we're hearing is we've got to get that balance between access and continuity right. So I think whatever model we come up with, and it's really for place to determine, so place geographies and with the local primary care teams. But we've got to make sure that the system is connected and we don't kind of have separate, in trying to think we're doing the right thing, for example, on access, we don't have a disconnected system inadvertently. So, and we just got to be mindful of that. I think that's come through quite strongly. Talking about finances and the current financial environment, you know, there's a strong theme coming through. How is the system, the ICB, going to support providers, primary care providers? And how are we going to support more around resilience of those providers? So I think they need a stronger narrative on that. So that's been made quite clear. Other comments about, do we have the capacity? And are we going to be able to, you know, do we have the capacity? And certainly with all the other pressures in the system, are we going to be able to deliver the strategy going forward? I think some assurance around that, especially around, for example, workforce. The workforce is always stretched, difficulties with recruitment, retainment, and making sure that we'll have the workforce to do what we want to do. So I've mentioned the kind of working with our patients and public and family communications and significantly important. And a lot of patients are not necessarily aware of some of the stuff that's going on. For example, the Pharmacy First program and various other programs, what all these new kind of additional clinical roles in staff and practices are doing or in the community. So I think they're quite keen to get involved and learn. Around the prevention, CVD focus. So again, mixed reviews. It's a system priority. Some comments saying that actually it's the right thing. Others saying perhaps it's too narrow. Should we be thinking of more general prevention? But again, I suppose it comes down to what do you have the resource to deliver on and keeping it tight, I guess. Digital, a big theme, making sure that we invest in digital programs and connectivity and interoperability. So again, that'll be key enabler. And as I said, on the engagement process, making sure that when we do deliver the final strategy, that's acceptable for all. I think there was some comment that some of the language perhaps was a bit complicated in parts. You know, we all know what we're talking about and using certain things, even though there was a glossary in the back, but you know, using terms like place. What does the system mean? What does place mean? That's a bit of an explanation around there. Something that was in the report was maybe more metrics, so harder metrics, perhaps wider metrics systems. Some of them thinking that they're perhaps too much focused on primary care, so a bit more system-wide metrics. And we've mentioned already the access around dentistry and pharmacy. So capacity in pharmacy, dentistry is a big thing. What is the system going to deliver on access to dentistry? So just some early analysis. Doesn't cover everything that we've had back, but yeah, happy to take questions.
Yeah. And I think just 2 points just to reiterate that. What's come through very strongly whilst digital may be an enabler, we want to be really careful about digital inclusion, and that came up currently for this patient for it. So I'm very mindful of that. And also a stronger narrative. What's it mean? How is it going to change? How is it going to feel different? Why will this be better? So just making it a bit more real as we move towards the final strategy. So the question that has come in has come from Dr. Richard Wood, Chief Exec of the LNC, relating to this paper. It's saying that the paper doesn't yet capture the views formally submitted by the representative body of general practice, and there is therefore the possibility that the board will not have adequate sight of the concerns of the profession. These include but are not limited to a lack of acknowledgement of practice and continuity of care, the GP identity, patient inequalities, the impact of preventative care on workforce contracts, metrics, the absence of building on current GP leadership structures. But we do understand that the paper was written before all feedback was complete. As this feedback presents challenges to the fundamental strategy, the board had a formal opportunity to review all feedback in a future paper which directly captures these concerns. So just a brief response. So the purpose of this paper was always to provide an update to the board on the development of the primary care strategy. And at this stage, we're simply giving an indication of some of the main themes that are emerging from our engagement, but we're not doing the detail. And we're still engaging with partners, and indeed tomorrow is an extremely important event, which is fine to discuss with a wider group of stakeholders. The final strategy will be presented to the board or approval in May, but prior to this, an engagement report and the formal responses from partners will be shared with all board members. In addition, the board will have time to discuss this as a workshop session in April, and when the strategy is presented for approval, we will outline what we've heard during engagement and how this is being taken.
Yeah, thanks for the report. Just picking up on the question from the public, actually, just for assuring that some of us have read the GP feedback and were quite grounded by it, actually. Just acknowledgement of how ground down practitioners are about the depletion of the services, about the stresses, and it's in the report under workforce, but that feedback really brought that to life, and then starts to tussle between the aspiration, the ambition against the foundation stone of where people and services and practitioners are was really hard hitting. So I'm glad that we are taking that on board. It has something we've already read it, and it will be part of the future conversation, because it really, where we want to be, and actually what the GP, what primary care practitioners are telling us, the gap between them is quite large. So I just want to say that has been acknowledged and read, and it's very much backed up with our own thinking, I'm sure.
I didn't see who was first. Aidan and then Minu, is that correct? And then Steve.
Yeah, thanks. Just a general question, really, and a genuine question too. What's this survey, this engagement that we've done, saying about what the public actually want from the primary care? Because I guess if you ask most people, they'd say, I want to be able to get appointments, but I want to see in 6 months' time, be on the phone for 20-hour MK. Beyond that, I think they don't know what they say. What do people say about what they want from the primary care?
Well, I think, I'm sure others will come in, but you're right, people want easy access to an appointment, so not holding on the end of the phone and an appointment in a timely way. I think we do have to balance that expectation with needs, as in who needs an appointment urgently within the next 2 weeks and who perhaps doesn't. The second thing that is important for certain demographic in the population is continuity. So the same GP, and that is particularly important if you've got lots of complex issues that you don't want to have to be constantly repeating what's wrong with you, what's been done with a different doctor every time. But that does vary depending on the sector of the population. People have different views on that. But Aberdeen might want to.
Yeah, I think you got it. And also joined up care. There's different teams. They're not interested in where they're coming from. They just want to make sure it's all connected and someone knows what's going on with them. Doesn't necessarily have to be me or the GP or Joy. It just want someone who's coordinating that. And then we have embedded up. I think there's a lot more that can be done. Certainly for the more complex, frail, and the life business.
Thank you. Maybe this is more for tomorrow, but the way I look at it is a strategy, a mature strategy will say, I want to address the huge challenges which are faced by primary care. I also want to address the challenges which the population is throwing out, is access, duration of appointments, safety, etc. And I want to address from the strategy the challenges faced by the system. And sometimes the message becomes much clearer when you delineate the same message in 3 ways. This addresses the workforce finances, the challenges primary care, challenges of the public and the population through cardiovascular prevention, etc., and how it contributes to the system challenges. And then that becomes where you address everything. Just a thought.
Thanks, Minu. I think it's really helpful, and I think it also aligns really well with some of the discussions we've been having about linking that through to the system priorities and exactly the way you described to articulate it.
Thank you. Very helpful. Thank you, Steve, and then Rachel.
Yeah, it was really good to get the update. And I said I just kind of fully not that I've been one of the people who've been saying about the level of ambition. And it isn't about the ambition, I think, in relation to what we want from primary care. It's the level of system ambition or the way that primary care services strategically are delivered over the next number of years. And I think that ambition is actually about how we see the ambition and expectation on the wider sector, acute, community mental health services, in relation to our interface around the work that primary care delivers. Because at the moment, it's my contention, George, others will have a different view, but possibly, but I think we've got an undeliverable set of expectations on primary care. So we've got an increasing expectation that primary care is able to deliver same-day access, expectations from the public about speed of same-day access that our primary care colleagues and organisations will deliver. And at the same time, we're expecting primary care to increasingly be leading and driving the work on health prevention, health inequalities, delivering continuity of care, managing long-term conditions, and those two things are just not compatible. So I think the ambition is about actually what is the role through the strategy of the provider sector, the acute provider sector, the community sector in physical health and the mental health sector in terms of mental health support around how we extend the work we do into and beyond our current boundaries into actually some of that same day access kind of support. So what we're not asking primary care to do is two fundamentally impossible things. That also starts to broker this wider conversation about how you start moving the distribution of resource into the sort of into the point of care that we're looking for. Because if you actually look at the way that distribution of resources is organised through public health, social care, primary, secondary, tertiary, quaternary care, the cost goes from left to right, or the expenditure goes from left to right. And this is about how do we actually take some of that expenditure that's on the right-hand side in terms of secondary, tertiary and quaternary care, and actually some of that resource being actually extended out to support the same day access services in primary care. So when I talk about ambition, it's not saying, George, need to be more ambitious of primary care. I think we need to be more ambitious about what you should expect from particularly the community mental health and acute sector across the sort of secondary to quaternary services and the way that actually we're supporting primary care in a different way strategically.
Thank you, Steve. That's really useful. I'm not going to ask Rachel to come back and hold that thought. I am going to ask, is there good acute representation but precisely that? No, really. Okay, thank you. And Steve, you bring up a really good point about our budget and basically, money for prevention. According to the Hugh report, we should be looking at 1%, minimum 1% being taken into prevention. So hopefully we'll talk about this at the planning stage. We're running late. I'm going to bring Rachel in. I'm going to ask George to close on that. And then I'm really sorry, Matthew, you've got to go on with that one in the other section. When you ask. So Rachel.
Thank you. So there's some general observations really. And a question. I do think it would be very, very helpful before we get to the main level to do some events at a place level as well as the broader event, because I think that places need an opportunity to really talk this through in more detail as the local system. I think that's quite an important aspect of development. And I guess from my perspective with this, we need to be really clear about what's going to be different as a consequence of this work. How is it going to be different? When is it going to be different by? And who's going to lose some resource to make this a resource change? So Sim mentioned the 1% from acute and mental health trust. So are we envisaging, and I know there's a lot of water to go in the bridge, are we envisaging saying, actually, do you know what? Knowing what we know in terms of the population need, pressure on primary care, the fact that we are treating people when they're further down the line than they might otherwise be, losing 5 or 10% probably we're going to throw it into primary community services. Is that the sort of change we're thinking about? Because it does need a step change if we're to realise any difference for our population now. There are always winners and losers in step change, and that's really complicated when you are overseen by regulatory bodies and you've got lots of pressure in terms of KPIs. But I think how to develop, given that we know, doesn't they, that public services as a whole, we don't have the resource base we require given the demographics in our populations. So if we're going to cut the pie of the thing, how are we going to cut it? How are we going to have that sort of discussion as we get to the conclusion of the strategy with your mind?
So, I think in terms of the place comment, I would probably look to the GP leadership group colleagues who have joined, Michelle, etc. And come from place to think about how that discussion could evolve. I think that's really helpful, Rachel. I don't want to make too many comments on finance. I might let him cover that in his section. I think we've started to look at some of those hard metrics. You know, how's it going to be different and by when? Some of them are articulated in the paper that Hannah's pushed, particularly around same-day access and the integrated neighbourhood teams. Part of what we need to bottom out tomorrow are those hard metrics, because there's a balance, isn't it, between ambition and pace. And what's really, really important is to take on the workforce and the public with us, because in some areas it has been rough, implemented in a way that we learned from them not to do. And so we're going to have that.
Yeah, but I think Steve mentioned summarised a lot of what I think on stage is good. But I think your comment about over-ambitious, under-ambitious, I think that's where the key is. So I think it's perceived as over-ambitious when it's seen as an ask of primary care to deliver this, when the current resource in primary care is not enough to deliver the core contracts on the basis of what things are. I think that's under-ambitious, and what my colleagues have picked this up is there's very little comment about obligations or expectations from the ICB or from our system partners within the paper having support this. And the Health Foundation document from last month, it was just an outstanding summary of the benefits of moving services closer to people's homes and into the community. And I know that, certainly in parts, I know everyone buys into that, the chief exec and, Rachel's here. So I think that's probably the big ask of colleagues is, can we be explicit about how will this be supported? Because if there isn't support from our partners in the ICB, we can talk about support being finance, states, whatever it is. It is completely undoable with where it is. And I think the other part that comes into that is our ICB being noted as a really an exemplar in their investment in the development and implementation of general practice leadership. There's nothing in this document where there's a clear commitment to that ongoing support happening. So when we attend regional events and people say, wow, it's amazing what's happening in Bob with general practice leadership, and we're really proud of it. We sing the praise of the ICB, recognising that, and if Steve had a lot to do with that, he's really interested. I think there's a real feeling that unless that's explicitly within the strategy, which it isn't at the moment, but that feels like it's constantly at risk or so those are probably the three bits. I think I'm now going to speak for us on this and to do so. But I think, realistic expectation we can't deliver this without support and everyone needs to be explicit about what that's for.
Colleagues, I have a feeling, thank you, Bill, that we're going to make up the time on this subject, and we feel and understand this is exactly how as system leaders and we need to hold this space. Rachel, I'm hoping that you've got enough information, guidance, select thinking, very helpful, constructive thinking to really make tomorrow count. And so that we can come back, as Rachel suggests, to this board with the next steps from the place involved. So this is a continuing conversation. We're not at the end yet, but thank you very much for stimulating this really important and vital part of our role. So let me move swiftly on, if I might. I thought Matthew and Steph doing a bit of the fun on it. And we're going to, it's two separate but linked papers, because we're going to review the delivery of the programs of the going forward plan. And just a little updates there, but also how we're approaching it planning because the two are really inextricably linked. So we're balancing as a system now transformation, which we all know we need, not with system recovery. So this is a huge steps, if you like. So what we've got to do today is this right place. We've got to approve the approach to updating the JMP by focusing on a small number of strategic goals. But we're also going to ask you as a board to delegate the draft to the CEO, the CFO, and myself as chair. So we need to agree system goals and a proposed system recovery and transformation forward that has been proposed by his team. So without further ado, let me go to you.
I'll take the first thing. I think that's a very helpful introduction. As we've already heard from Nick, there's an enormous amount of work that's been going on over the course of the last few months, frankly. I think given where we are, there's a very key collective direction towards avoiding the worst outcomes of NHSE, oversight, etc. That do not fall. Everyone's very committed to that. Yet the gulf between our financial delivery and avoiding that, I think, is significant. I think that's no surprise given where we are at the end of the year, and we'll I think forecasting the end of the year in terms of the pressures we're under, and we'll get the opportunity to talk about those a little bit more later on this afternoon. In terms of what we would do about it, I think there are a number of key planks. One, an adoption of ways of working that are consistent with, not four ways of working in any case. And secondly, we talked about both an internal recovery board, but also the recovery board that's explained a little bit more in this particular paper. The return that's going tomorrow will be the first one that goes in for individual providers. In aggregate, will build up to the overall ICS position. The ICB itself will take quite a lot of risk in that. Again, we'll pick that up later on this afternoon. Yet, I think there's an overall requirement to hit break even. Sitting here, that's going to be an immense challenge. Again, I don't think it'll be a surprise to anybody. Yet, that is the ask. So I'll hand over to Hannah on that note, to confirm the approach to what we do with that.
Thank you, Matthew. So we're trying to do a couple of things today, so I'll just take them in turn. Obviously, we published our joint forward plan in June 2023, and already the time for annual review, although it's May, I'm sorry, March, is on us. So what we've done is we've built on our discussions over November and January in terms of recognising the JFP ambition is really well brought into across the system, that it has 100 deliverables, and how do we hold that in the challenging environment that we find ourselves. So the paper on the JFP gives an update on some of the key areas of delivery against the 4 challenges within the joint forward plan, and also sets out where further detail can be found where we're tracking the remainder of those 100 deliverables through business as usual forums. And then it provides us a hopefully kind of segue into our system recovery and planning paper, which builds on our discussion that we had in January in terms of distilling our ambition down to a small number of goals. And I guess some of the discussions we've had today, I've been reflecting already that we often do things in the NHS where we've all seen kind of strategy sections of an agenda or strategy papers, which potentially feel quite divorced from a discussion on the finances and the reality. And so what we try to do in this paper is actually bring it together, recognising that the context within which we deliver the primary care strategy and also our other system goals actually is really challenging, that we're probably drawing on the same leaders, the same transformation resource, the same bandwidth, time, headspace, all these kind of things. So actually, we've only got a good shot if we bring it all together. And picking up on some of the comments in the room already today, in terms of kind of Lina's test on is it meaningful to the public, is it meaningful to our workforce, is it meaningful to our system? To Steve's point about actually these are system kind of shifts we're trying to see, and they're only going to work, as George said, if we pull the whole system together. So what the paper tries to do is say, actually, the goals we discussed in January, can we And we use those same goals, but refocus them, recognising that as leaders, we've got to balance our kind of system recovery, some of the points that Matthew was addressing in terms of our financial sustainability on one hand, with the limited numbers of areas that we can't not invest in terms of prevention and transformations and models. And how do we best do both? So our kind of proposal to that, and Nick might want to come in on this, is that from April we will set up a system recovery and transformation board, which will hold that kind of leadership challenge of how do we balance these two kind of key aspects in our system. And I just draw your attention to point 11 in the paper, which I think is really key. So it says that to achieve the level of transformation we require, we'll need to develop greater clarity around our shared direction, followed by closer alignment and coordination of our total system resource. And there's a kind of model around system leadership that talks about how you need shared direction, clear alignment and real commitment from partners. And I think those are the real tests actually if we're going to pull this off. Can we ensure that our discussions around the money aren't just kind of on the money, but actually they're about how you reshape, respond to demand differently? And can we ensure also that our discussions around prevention and reshaping pathways aren't just seen as the nice to have, but also the solutions to the financial situation we face? So the paper's all about kind of gluing it together. I won't say more apart from the next steps. We've got some detail in the paper on what we think the deliverables will be on the prevention and system transformation goals. We haven't put much detail in terms of the recovery improvement goals because that's still ongoing sort of the planning round, especially with partners, the work that Alice appeared to do, and a piece of diagnostic work we want to do with the system, which will help us diagnose how are we in this space and what are the real programs of work that we should go after together to result in a more sustainable system.
Yeah, so just building on what Matthew and said, clearly the situation we find ourselves in is incredibly challenging, both from an operational and financial perspective. I think we need to adopt a certain amount of mindset to address that. And we need to ensure that we work effectively as a system and realise the benefits of working as a system, which I don't think we've fully done as yet, but understandably, it's a can't change history. But I firmly believe, I said it a lot, that this system has the reality to be a really high performance system. There lies one of the challenges for us because other people think the same. Therefore, we look at our metrics and are in fact disappointed by where we are. So I think this approach is what we need to do, and we need our system partners to get behind us and for us to work rather differently to perhaps how we have been working to date. I also think that this is expected of us, and we currently have in our own gear to resolve problems we're facing. But if we don't get on with this agenda, the approach will be imposed on us. And I think we all want to preserve the agreements as well, not least because of the rest, but we way to work most effectively in the system.
Yeah, and 2 or 3 things. First of all, I think it's excellent person today. It's really refreshing and invigorating to see positivity that's in it and the realism. It's got a good combination of accepting reality, but also having a tangible plan. And when you read the appendix, it goes into a little bit more detail as well, which is good to see. I think it plays very well to a lot of the conversation that we have already on the primary care strategy and various questions that Rachel asked and George has immediately proposed to us. And now square a circle of service improvement with resource challenges. So I think it's good. It's the first step on the road to a solution, I think. A couple of other things, observations and comments. This is, I think, the little graphic is a really good way of encapsulating it. I think that's very much what we should have it all hopefully burnt into our minds and in the coming months. This is what we've got to do, because what we cannot do is do everything. We talked to everyone in the primary care section about patient wants. I think Rachel was spot on when she said we need to focus on patient needs. We all want lots and lots of things, but in the current climate, we cannot have everything we want. I think it's important to say that in a public meeting as well. We have to do the best we can for our population and our patients, but that does not mean we can do everything they will want. Almost the most important metric is outcomes, not necessarily satisfaction. They're not the same thing. And I think it's difficult, but in this current climate, we have to consider that. I think the other important thing is about the timeframe. Dan, right at the beginning, talked about some of these projects on the ground needing more than 1 year's funding. I think this plan needs more than 1 year's focus and support. Obviously, with Alistair being here, I think it's an important part of our journey in the coming weeks and months. We need to get this understanding that this is going to go into not only next year, but probably beyond financially. I think that's a really important thing to focus upon.
Sorry to interrupt your plan. There are so many people who want to come in and we're against time.
Okay.
You said most of you want to stay. Can I bring in Aidan, Rachel and Steve? And I need to close the time. Sorry, Aidan.
Yeah, just a quick comment, really. I mean, it's the J element of the joint forward plan. I thought that your comments about the session on Friday earlier were absolutely spot on. I think that was a great start and really building on some of those relationships for cooperation and for working together. But there's another element to this as well. Recognising the challenge that we face, we've got to all commit as a system to working within that financially stressed environment that we're in. And I think we need to grapple with the other side of the joint forward plan relationship, which is not perhaps, I'm picking my words carefully, it's not quite as cooperative as maybe the other part of it is that we were talking about pressure, which is great working together. But some of it's got to be a bit tougher. We've got to be a bit clearer about the position that we find ourselves in, and I think we need to kind of draw that out in this conversation.
Rachel, Steve, and then Tori.
Okay, thanks. In order for us to be able to realise these system goals, it feels as if they're going to have to be driven at a place-based level. So it feels to me as if what we're saying is we're now going to be directing tasking place-based partnerships to take on this work in addition to very distinct priorities. And I guess I'm very interested in the how and the who. So who's going to really drive this stuff from the ICB organisation? Have we started the negotiation with place-based partnerships about actually we now want you to also lead in to this stuff if you're not already? What's our readiness assessment of how able they are to do that if we're going to get traction? And then secondly, and this could be an offline, I'm fascinated in paragraph 14 and what the investment funds are coming into Bob potentially with the social investment approach through councils, VCSE. So I don't know if that's a social impact bond model. I don't think there's much proof that social impact bonds have got any traction nationally, but perhaps that's not fine conversation. Thanks.
Rather than take it all now, I'm going to ask you to store up. So I think it was Steve next, and then.
Yeah, so I think it's good to take two papers together because I think, as we just alluded to, we're entering into the second year of the joint forward plan. So we need to have our orientation about resource allocation for next year is about how we advance the second year of the joint forward plan commitments. I think there's a further step on about bringing those two things together. Could be how, in the context of the resource allocation we've got, because whilst we have got a challenging financial environment, it's somewhere between 2.5% to 5% of the ICB's total turnover in terms of resource deployment. So we've got 95 to 97.5% of resource we're going to deploy. And how do we think about that deployment that actively advances the 6 areas that we collectively, including providers, said that we're committed to? So there is a level of growth allocation that we're kind of thinking about how do we allocate. So I really encourage us to think about that allocation, both collectively, but with the commissioning view of, okay, how does some of that growth allocation actively support, I mean, I've picked on the first two, integrated neighbourhood teams and a virtual hospital, virtual wards. So, any growth allocation, again, personalising, coming to our BFT, how are we going to demonstrate that some of that is going to be actively used towards these commitments in year 2 of our joint forward plan in the way that we're supporting primary care strategy, supporting George and Abby and colleagues in terms of integrating neighbourhood teams by pushing more about front end resource towards that, and actually taking on the responsibility again of expanding the virtual hospital capacity, virtual ward capacity, to change the dynamic around same day access. So I think there's a way we could take a further material step through some of the sort of commissioning intentions about how resource we can allocate can actually support the joint forward plan commitments we've got here. And I think two things can be true at the same time. We can do that, and we have to be really hard-nosed on ourselves as a system leadership group about the fact that we have got a challenging environment and a financial deficit that we have to bridge through some of those through efficiencies we need to commit to. So I think both of those things can be true at the same time.
Thank you, Steve. That's really helpful, constructive.
So first of all, thank you, really, and welcome both the papers. And just to highlight, there's maybe a little bit of a gap with digital data and technology, recognising it links to population health, but I think the opportunity to be able to digitise all our providers and services when we're looking to connect all the different data flows. And then lastly, there's currently 15 strategic programmes that are running across farm, funded often by NHSE and other excellent. But again, those programmes are trying to, again, support things, for example, like instruction and making sure we utilise the NHS app. So just to say, going forward, if we can maybe have that as a section, that would be really helpful, but really welcome the intent and the ambition behind it. But just want to call out those enabling capabilities which we need to keep to support that.
No, thank you. Do you have any final comments from you? Just say it closely. Yes.
Yeah. So on to your point, you might remember in January the graphic had a bit on digital, and I'm afraid the slide was iterations off that, but we'll be stated because we can't do any of this without digital. To Steve's point, I completely agree. In some ways, I feel like I'm saying kind of what are quite boringly radical things today, which is that sometimes in the NHS and wider, we don't resource and we just say these are our priorities and we don't think about what actually is required to do this and what does that actually mean in terms of bold decisions around how we allocate money, but also how we need change, both in terms of our public, but in terms of our actual workforce who is doing this as their day job. So I think that underneath all of this, actually, even though we've got 6 things there, delivering these will be very hard if we don't kind of grapple with that. And then Rachel, to your point, I guess it's a slight difference of framing actually, because on the graphic it says goal system goals, and this is in some ways a kind of overlay across what is already going on in place. We've all heard the Richard support Dan was talking about. And this is where we think that our 3 places are going after similar things. And the primary care strategy is an example. We're not going to prescriptively say a do once approach, but equally, if you've got 3 different places developing integrated teams, what are the links, what's the sharing learning across that? How do we use our resource well? Where there's also problems like our children and young people's mental health and some of the neurodiversity weights that cuts across places. And then where within the recovery mindset, actually our system plan is a system plan, and we're going to have to think about different elements of resource allocation across provider collaboratives and across our organisations that sometimes might mean that a certain place isn't that because actually we need to sell state here to fund something else, and that's really the framing of this. So it is a build on what we do on place, and the kind of complexity is holding the 2 together, I think.
Guys, as well. This will be reflected in how we work as an organisation, how the executive team works, the creation of the delivery unit, how we refresh our effective management committee, etc. So these priorities will be front and centre in how we go about this and this way. I'd conscious as well that there are people who ask which rules might they don't get to sign.
So that there are 2 others actually. So we need agreement on the delegation of the draft plan submission to the CEO, CFO, and the chair. That could be submitted on the 21st of March, which is Thursday, isn't it? So if I could have general nods agreement for that delegation. Also agree to the proposed system goals, but mainly recognising, I think, the shift towards balancing this transformation with recovery. The 2 are category government. So I think if there's an agreement on that general shift and the narrowing of those system goals, that would be very helpful to us to be able to move forward. And I think this board notes the proposed system recovery and transformation board as a solid idea to try and help us alleviate the difficulties we're in. And we also note the system's approach to meeting the national planning expectations. As difficult as that is, it is our job to try and get there. So despite the national guidance not coming through, we will do our best to submit and publish on time. So thank you, colleagues. Really fruitful discussions. I'm going to give you a 10-minute break, so if you could be back at 12 o'clock. Back, everyone.
Yeah.
To apologise to those online. I understand that you stand, it's not as good as it could be. So apologies for that. We've had a little bit, but we're able to do much more. So I ask for the presenters to be as clear and use their best stage voice as possible. Thank you. So apologies for that, members of the public. So we now have our public sector equality duty annual report. As you can see, it's very long. We will not ask Sandra Grant, who's going to present through everything, but we thought it was important to bring it this year. This is our first full year of points, so we thought it was important to bring. And also we need to agree the equality objectives for 24-25. And I think they're on page 17 actually, they're not big deal. So that's why we brought it. So Sandra, welcome, thank you very much. We've all read the very full report. Thank you very much. We're going to ask you just to concentrate and pull out a couple of the key points, and we know that we need to improve the equality objectives for 24-25, surely 17. Over to you, Sandra. Thank you.
Thank you, and morning everyone. So I'm Sandra Grant. I'm the interim Chief People Officer as part of the People Directorate in the interim Deputy Chief People Officer. Just checking you can hear me okay, because it was a bit sporadic with me hearing you. You can, fab. Okay. So the Public Sector Equality Duty Annual Report. It's predominantly been the work of Yasmin Mahmood, who is our EDI lead in the organisation. So big thanks to her, and then contributions from lots of other people, because as you can see, it's a very in-depth report. So just as a bit of background for the report, it's required by public duties to publish this kind of information annually on how they're complying with the equality duty. Specific for ICBs, we're required to show due regard for the 3 aims of the Equality Act 2010, which is all about eliminating discrimination, advancing equality of opportunity and promoting good relations. And included within this report is a specific duty to publish information on the gender pay gap, and that's now on the relevant government website that we need to submit that to. It's also specific about having workforce and service user data, which is analysed by the protected characteristics, and to agree at least 1 equality objectives, which I know, Sim, you were talking about earlier. We have a few of those that we're proposing on page 15 of the report. So there's 4 key sections on the report. Section 1 gives background and context to the Act itself, and how we work within the ICB with our partners and the engagement plan. Section 2 specifically focuses on health inequalities and where we're targeting programmes of improvement. Section 3 looks at workforce. What's the data? What's the trends we're seeing? What's our staff engagement processes telling us about that? And Section 4 is looking really about, our promoting good relations bit, how we're working with our partners in our communities to make sure we have safe working, good education around inclusion, etc. Other aspects of the report to note, it's a retrospective review of progress so far, but also sharing our plans for the year ahead. And that's not only our plans for the ICB in this area, it's about the system as a whole and at place. The report itself, there isn't a prescribed format, but our report is based on best practice examples shared by the Equality Human Rights Commission and through the work we're developing with fellow ICBs in this space. It's linked to, you would have heard of the Workforce Race Equality Scheme, the Workforce Data Equality Scheme, Gender Pay Gap, Equality Diversity Delivery System, all of those things all joined up together in this place, really. So that's a very quick run through, and now just to be clear about what we need from you today, if possible. So we're asking you to approve the Public Sector Equality Duty report so that we can publish that, which is a requirement of us by the end of March. And then to discuss and agree the equality objectives, which are set out on page 15 of the report. That's a distinct legal requirement. Those objectives, just to provide some assurance, have been developed with partners, have been contributed by the People Committee and the Executive Management Committee. 3 areas of focus for them: public engagement, maternity, particularly about equity of access, and workforce. Those ones focus just on what's internal to the ICB. That was the end of what I was going to say today, Sim.
Thank you very much, Sandra. Really important report. Colleagues, I'm sure you've all read it. It's our duty to publish that. And so what we're asking you today, as Sandra said, is please, do we have permission to be able to publish this on our online? Yes, I think we've got nods, Sandra, yes. And then any comments, please, on page 17, actually, is the draft quality objectives. That's about slide 15. Oh, slide 15.
Slide 15, thank you.
So public, the sort of draft quality objectives, so the maternity, public engagement, and workforce as the key areas of focus. I have general agreement that those are acceptable areas for 24-25, not all around, Sandra. And as you did say, this has been through the People Committee, the ICB People Committee for scrutiny. So we've had a good look. And we'd also like, please, Sandra, to thank Yasmin and all of those that have contributed to this report, which is really important for us. And I know that we also committed, or I asked the People Committee, that we'd also think about publishing our ethnicity pay gap as well as being moved forward, and we can collect that data. We're not in a position to do that yet. I think it's good practice if we are able to do that. If there are no other comments, sorry, Nick.
Yes, sorry, Sue. And so just thank you very much for your report. I suppose just building on the conversation we had earlier in relation to the stats survey, delivering on our ICB quality objectives is clearly essential this year. So I very much welcome this approach, and I know that colleagues across the organisation are very key that we demonstrate commitment to delivery in relation to these objectives.
Well said, thank you. Thank you very much, Sandra. Thank you.
Thank you. Bye-bye.
Colleagues, moving on, we're going to take the performance and quality report now, a combination of Matthew, Rachel. And this is about assurance, actually, to give the performance overview and where to note and discuss. I think I don't realize anything because I know what my colleagues are going to answer the rate for 65 days that we see in particular. But also note that this information is updated, and I think Matthew will speak to that. So give us a more up-to-date position, even if numbers aren't on. So
it would be helpful really just to focus on national priorities that they referred to earlier and where we are on those at this present time. Bearing in mind that there's a lot of validated data, so isn't data that can be confidential or give a broad indication of performance. So I'll just go through the four areas and give my contextual aspects. 4-hour target, long waits, elective care, cancer rates, and moving step 2 performance. So those are the 4 national priorities, and there's a real push for demonstrating across the NHS, across the country, that we've been bringing on those targets in March, and there is escalated assurance oversight and incentives to support those as well. So UED, so the target push is for 76% during the month of March. We have struggled to deliver that so far. Latent and validated performance from the system is 70.2%. We have seen 2 continuous weeks of improvements for the last 2 weeks in terms of that number. There is a degree of complexity with the number. It is unvalidated, therefore it doesn't take into account necessarily all the activity that takes place in all our different units where they're not emergency departments. So we're still working through that, and that could have an impact somewhere between 2 and 4% in terms of that position during the course of March. So if that's a pilot 4, then we would be getting towards 75. If it's lower, it would be running at 72. Our comparable performance is relatively low across the South East. Particularly when you take into account that estimated MAP activities that referred to. If you looked at performance in ED departments, then we would be more midpoint, but actually we are the lowest performing system on the combined measure at this point in time. We have put additional insurance in place. We've worked with all our trusts. They all have improvement plans in place. We went with the regional team for a visit to Oxford last week, I think, recently, and the last fortnight, just to have a walk around and see some of that improvement in action. We put in place additional primary care based support models, so investing in additional opening times for our UPC options, investment in affordable assessment services. We've written to our local authority colleagues and they're doing a great job of supporting us, but just to emphasise the focus on this particular targets, and we will continue to work closely with our trusts around that. I'll take category 2 performance next, so that's ambulance performance for category 2 patients being below 30 minutes. We've had a really difficult week over the last week, 10 days on that, and that's now tipping well above the 30-minute target for the provider, and that's been influenced by high level of delays across the system, and there's a particular issue in port circumstances and other challenges there. That is a real struggle, and we were doing very, very well up to that point last week, and that's seeing some pressures as well. On elective long waits, if you've read the report, you'll see that at the time of writing, we were forecasting we may have some over 78 weeks at a number around 41, I think is the number quoted in the report. Unfortunately, we have seen that number increase at the Oxford University Hospitals Trust. That's been driven primarily by a patient choice cohort, where as we look to secure bookings, those individual patients for a number of circumstances that may not suit the individual concern, and therefore they choose to have that delayed. There is a technical debate now if you want to start with a number of options that won't formally be counted, but actually in terms of the number we're currently forecasting around 80 for the end of March, if targets of 0. On cancer, the focus is those patients waiting over 62 days, which we've discussed a number of times at this board across the course of the year, and trying to reach what was been through the fair share targets set by HSC colleagues across the system. You'll be aware that we've done some focused work in this area before. We have seen some really impressive improvements over the last 3 or 4 weeks, particularly at university hospitals and Buckinghamshire Hospitals in terms of a significant reduction in our numbers, and we're now expecting both of those organisations to be below their fair share targets at the end of March. We've had some more challenging numbers around the Royal Berkshire Foundation Trust, and they've struggled with capacity in terms of getting down to that fair share number. That's been known for a while, and we're working with the trust on how to address that. There have been some reductions in the RBFT numbers, but they were likely to reach their fair share targets at the end of this year. The system will make just about get better to the cancer 62 days. So they're the key ones that there is a lot of focus on. Weekly assured sessions of our engineering team, but I wouldn't acknowledge the work that's going on in all our trust. They work exceptionally hard to deliver those targets in difficult circumstances. We've had lots of work going on. Right, so that gives the board playing for the more up-to-date numbers in terms of how we have in progress.
Thank you. I just wanted to pick up the theme of learning disability, particularly in light of the fantastic presentation I had earlier. Do we already have a cross-board learning disability focused group to look at issues around inpatients? I guess my experience is the only time we ever really successfully move people into the community is if you use some of the resource to establish community-based interventions alongside housing and specialist support. And I just wasn't sure whether or not we already had something like that in place. Thank you.
I'll pick that up, Rachel. So one of the things that each basically needs is an executive to support disability. So I have the privilege of that mantle. So we have kicked off a learning disability and autism board, which my deputy chairs on my behalf, multi-professional, interdisciplinary, and the group will be focusing on the wider transformation programme, which is the way that we describe. We have quite regular interface with the region that monitor our activity around inpatient care, and we're monitoring both those in acute services, but non-acute services. And as you say, you know, in like the timely conversation that we were having this morning, we want to make sure that we've got the right oversight on the waiting lists and tracking this. And some of you will have seen the report published last week that's also linked to the story that's in the level of trust about preventing those with no awareness is starting too young. So all of that is built into our elderly young programme, and that will be into our population. So thanks, Ian. Thank you.
Thank you, Richard. You can answer on that, it's difficult performance. I don't know, Steve, you want to just give us a sense from the acute provider point of view, if exactly how difficult it is at the moment? We heard there's quite large numbers. Is there anything to add to what Matthew said?
Yeah, so well, probably two things. So I think there's also the balance between, you know, the performance, quality, safety, actually, perspective, because some of the challenges within the sort of UEC pathway and coming to a head often within emergency departments is the sort of safety aspect of particularly those attendees who are attending through an ambulatory route, and how we're actually managing kind of overcrowding in that space. So getting that kind of balance right is a really important focus. Certainly from our perspective, we've seen in the first half of March, again, attendance is up in excess of 500 attendances a day, between 400 to 500 attendances on a number of days. So quite a significant level of sort of volume coming through. And the profile is still interestingly the same. So because of all of the work that has gone in collectively around things like same-day emergency care, not just in terms of kind of adult children and other sort of ways, what we're seeing is our admission profile is pretty much the same. So it's running about 70, 75 admissions a day. And that's been pretty stable. So a significant proportion of the increase are often people coming with ambulance who are not necessarily being admitted. So that volume issue at the front end, but what it does mean is the 75 to 80 people we're admitting a day, their acuity levels are relatively high because we effectively are filtering out into both hospital, SDEC, pop clinics, those patients that can be treated in a different way. So it's a kind of both challenging and interesting profile in terms of higher acuity into the back end of the hospital, a level of volume which is often ambulatory driven at the front end of the hospital, and therefore, you know, within that context, particularly times during the day, going into the evening, keeping that environment safe.
Yeah. Something in between. Thank you, Jen. Just in terms of the 76%, Matthew, where are other systems on that? Are we an outlier? Are we in the pack?
Yeah, so within the southeast, we are an outlier. So we are, if you look at the present predicted mapped activity, we would be the lowest performer in the southeast. And the southeast is doing very well. Probably the best performing region nationally. I can't be quoted on those numbers, but I think they're doing very well. They're almost at the 76, so it depends on week by week performance. They're very close to it as a system, which indicates that a number of systems are doing better than us. We are all working on that mapped activity to make sure it is absolutely accurate. I suspect that may improve our numbers comparable to the rest as we approach the end of March. So I think there are 1 or 2 examples where we perhaps could map a bit more activity, but our performance is not strong as these, but it might be too strong. So that's where we are, and therefore we're quite understandably, but there's a degree of assurance and escalation around that performance that mutual team.
I mean, I'm not being quite seriously, but I mean, are they doing something that we're not doing? Is there a trend there that you know? I mean, I'm sure you've looked at this, but is there anything that's tangible?
Yeah, so we continue to look at that. You know, there's 10 high impact changes around urgent care delivery that we're We do regular assessments on. We have best practice across our system that we continue to look at. Some of the Oxford models around same-day emergency care and virtual wards are some of the best in the country, and actually presented to a UEC improvement event only a couple of weeks ago. So absolutely, we continue to do that across the system. I think, to be fair, the whole of the South East has stepped up. So if you look at the trend performance, you're going to see an exceptional bounce back in March. Whether it'll get to 76% is that's the judgment that's on us. But actually, in terms of the work that's going on locally, there's a lot. And for example, we're looking to put more consultants in overnight, and that's that does cost money, so there's some financial risk around that. But there's a lot going on, and we continue to share. Sorry, I'm Rachel. So Oxford have also been down to see some of the better performance trusts to try and get
Rachel, is your point on this?
Yeah. So as Matthew said, absolute learning from those providers who are doing well in the space. I think it's important when we talk about mapping activity, we have different models and different systems. So those systems that have, for example, lots of urgent care centres, lots of minor injuries units, that all contributes to mapped activity, and you would expect those patients to be seen in a very timely way. So there are different ICBs that get different degrees of uplift depending on where their activity sits predominantly within the interval.
On the electrical, the weights in 65 weeks, 78 weeks, the doubling in the long term wages and things the way and that we don't exclude the patient choice, we closing lots and having elective. If there presumably is a standard about how much notice you're doing, is this a kind of budgetary end of year in February? We suddenly get rid of our 78 long-term waiters, people have been waiting over a year, giving 2 weeks notice. How does it look from a patient perspective?
No, I think from the patient choice aspect, it's as you approach the year end, it just becomes a reality. There are a number of patients who may be booked in that they've actually convenient. So there's a lot of effort to try and rebook those within the time scale, but it's not a budgetary issue at all, Margaret.
So they're giving notice, they've been waiting over a year, they've been waiting 7 weeks or something. Are they giving notice to plan their lives accordingly, or?
Yeah, in terms of the specifics about how long we've got from advance, I'd have to take that away to look at, but
it's not health watch and others think about patient experience of that.
Yeah, and I think it's
financial pressures in the end of the year and so on.
Yeah, I mean, I think so. I don't think it absolutely it's not going to do with a financial cross-year issue. Of course, there is a desire to treat those patients before the end of May, and that's seen as an important. Before the end of March, but an important performance area. So there are efforts to get patients booked in. I guess in the patient experience, that may mean that people that we are offering appointments to get them booked in at relatively short notice. That may be the patient reality, but there is the desire to get those patients booked in and treated, and they will only, there'll be a attempt to rebook those patients as soon as possible. But it's not a financially. There's not a financial incentive there, and that's managed. So let's see if you can add it.
Well, it's at the heart of the question, if you are we, as we approach deadline, kind of giving people on future notice to be able to, and then when they see that, they're saying, well, that's your choice. That's not how. So, the whole approach in terms of, I think all the organisations got the 6.2 programme in relation to theatre efficiency, which will give about 6 weeks, 4 weeks, 2 weeks in terms of use of capacity. You take consultant and other clinical leave into account, which is often 6 to 8 week book. So you're looking kind of well ahead in relation to that, including often it's patients who require certain types of treatment, particularly patient treatment, which is a lot of waiting. The waiting patients will need some form of pre-operative assessment as well. So actually, first off, notice. What we do as well, though, is look for those patients who are prepared to be offered short notice as well. So they may well get, if you're able to be offered something within a very short notice period in a week, so would you be willing to take those? But in general, actually, people are offered something that's like what works.
Thank you.
Thank you, Margaret. Patient experience point of view. We're moving on now, please. If there are no further questions, Matthew. busy talking. Matthew, are you happy to do the finance reports for January? And we know it's not a position actually that any of us would want to be in. And I also note actually that because the ICB wants to achieve its statutory financial targets, it's important that this board understands that the external auditors have issued a Section 30 report to the Secretary of State. So maybe you could explain to all of those here present what that means, Matthew, and the consequences, please, on that.
Yes.
So,
Sure. So I'll come to that in a moment, Sim. I mean, just to give the highlights, yesterday the ICB is 6.5 million deficit for month 10, forecast outturn 40.3 million. I'll come back to forecast outturn in a moment. The overall ICS yesterday 47.9 million deficit, and forecasting to the end of the year a 73.2 million pound deficit against a system plan position of 20.4 million deficit. Those days are clearly quite clear within the report itself. What has been the subject of discussion over the course of the last few weeks, frankly, and also particularly within the System Productivity Committee, is around the movement month 10. Clearly, when we set out at the beginning of November to deliver the 26.3 million down deficit stage that we aim to end the year at, we have, despite all our attempts, going to meet that goal. Again, I think people are fully aware of that. I think the number of moving pieces since then are quite considerable, but at the same time, we also must acknowledge that was within the bounds of what was possible at that stage. Recognising the 26.3 is a tough call for us, and indeed, aspiration that we should have thought, but at the same time not managed to meet. I think the contributing factors, I think more importantly around month 10, are significant. And I think we've been written to by an Eden, so I think again everybody would be appreciative of that. Who has asked an explanation. We wrote back again last week about that. The main moving pieces within that, I think, were 3 buckets. One which is system related, sitting within the ICB. 2 that are within individual providers, and 3 within the ICB. The response, which people may or might not have seen at this stage, but nonetheless, I think each of those points reasonably clearly. The system level challenges, I think, are level within TBCA, that's the Thames Valley Cancer Alliance. Secondly, around the Electric Recovery Fund, which are 2 factors that are key points of play within the system. Within individual providers, Oxford University Hospitals moved out by 5 million. Again, in very brief summary, largely to do with staffing. And then within the ICB, we've had a continuation of pressure within high-cost drugs and around continuing healthcare. So, there's a lot of detail behind each of those bits, which we've discussed within System Productivity Committee. We've got a set of actions against each of them. And when it had to tighten up in a number of the areas, I think one of the main areas is around an ICS system recovery group, but that will have then sort of a cascade of specifics around the ICB itself, and also around some of the ways that we're going about a financial governance review, and hence, one of the prime reasons why we've got Alistair now conducting that review. I think at the heart of this are how we go about forecasting, and how we go about the communication associated with that. I think all of our forecasting needs to be understood in the context of a mutually understood set of risks and opportunities. And I think we clearly hope to count on what are quite a few moving pieces if you take into account industrial action that's undertaken through, these pieces through the course of the last couple of months, which are clearly big factors. I'll stop on that note, I think.
clearly ready to take any questions, but I think otherwise let's in your report.
Section 13. There's two extensions.
Sorry, yeah, from good ask. So this is really just notification. The direct consequences of this not nothing that we've been made aware would flow directly from that. I think the things that we're more concerned about is how this puts us in the NHS OSAP framework position.
Do we know of other systems that have been issued a second penalty? Are we the only
Any system has methods, if it's sort of statutory requirement, will be forced in the sense to issue this notification, and there will be many of them.
Matthew, may I ask a question before I bring others in? The Thames Valley Council Alliance, and you've sort of pulled it out as a risk, an actual risk, but yet we hear that we're going to be taking over the hosting of it. So sorry, in my mind, as simple as I may be, those two things don't tally. It sounds as if we're taking on a risk. Please, could you clarify that for us and help us all understand why we've been doing that?
Okay, well, I think a couple of points, and Matthew may want to comment too. At the same time, I think from a TBCA perspective, we were taking quite a few of the issues associated with TBCA and how it was funded in any case. So, in a sense, in-house, they wanted to give us more of the control over how it has been managed and the ability to put the right resources into supporting the distribution of the funds. I would also add, I think, improving communication.
I don't know.
Thank you.
I think from my perspective, this is fundamentally a dispute between the ICB and providers in terms of flow funds, not around Thames Valley Council Alliance governments and decision making. So we made a planning assumption quite transparently in the last planning round about the likely allocation from the Thames Valley Council Alliance provider trust. The provider trust took that into their position. I didn't quite match with the Thames Valley Council Alliance decision making, and whilst we worked through those allocations for our provider trusts, the ICB is taking that risk to the position. So this isn't a risk that will materialise and be relevant for the transfer of the Thames Valley Alliance into the ICB. I agree with Matthew's point that as part of that transfer, we need to make sure we have a better understanding of funds flow, but it does not enter as a lot of things about Council Alliance cutting into this. I say it's a complication of funding flows into the system.
So you are assuring this board that by taking over the hosting, there will be firmer control. Yeah, more robust governance.
I mean, the incident of this, I think we can confine to 23-24, to be clear. So it's not a recurrent challenge. Yet at the same time, taking the TBCA is not risk-free, but as we described earlier. But nonetheless, this specific issue, I think, can be avoided.
So this both appearance for the answer. You, Rachel, on the same point.
Well, relating to the risks that the ICB are holding, can I just want, apologies for clarification, just want to understand why the ICB is holding the ELF financial risk and not the providers. I know it's a difference to the system, position, but just for clarity.
So ERF clearly flows into the ICB and then out to providers. There are assumptions that are made about additional activity that will collect EFA. And then on the other side of that, some assumptions are made around what payments can be made out to providers, not just within our system, but NHS providers outside from being a good case in point, and also the independent sector. I think the matching of that income with the payments has been a challenge for us for a number of reasons for the most part of this year. I think we're getting better at it. Some of the factors that play into that are the fact that we rely on data that NHS gives us, which tends to be 3 months old, so you're projecting from that. Secondly, the data that is the true measure of activity is coming out of SAS, which is the sort of system that describes activity. Yet the NHSE data, we've had a lag on it. And then second, sort of finally, if you like, or closely aligned with that, it's I think we're emerging from a period where we haven't been used to operating PBR. And I think as a consequence of that, the protocols around how that forecasting lead the group.
Sorry, Nick, then finally taking that.
Imagine a set up by but yeah, I think two areas to be really interesting for the board to maybe reappraise itself with, and I have in my mind the conversation that we started with, which is around simple language. You know, I think simple language should be our watchword on this. The first is around cost controls and how we draw the line between cost control, governance, and financial performance. And in effect, how we can begin to potentially leverage our growing relationship across the system, again, if it relates back to the Friday, to kind of affect some of those cost controls more meaningfully. I must admit, it's one of those subjects I do think that I've got my head around them, and then I'm not sure. And given we are where we are, it would be, I think, really helpful to revisit that. The second point, question would be around structural challenges. So the kind of the potential for the challenges that we're seeing this year to be repeated again next year, which I suspect can be quite strong. Again, from a really simple kind of overview of that, the board, of how we can understand where those structural challenges are, I think would enable us to, to revisit some of these subject areas. And I know these are dealt with, in the committee, Tim's committee and elsewhere, but I think just it would be helpful for us to kind of revisit some of the fundamentals so we can go back and we really assured ourselves that we're getting to the sufficient level of detail we need to.
Thank you, Nathan. I think that's really helpful, actually. Given the state of the financial position, it seems to me that actually more visitation, sort of scrutiny, but more being aware of and being very clear of the levers or not, and how we spend our money is actually that this board needs a bit more visibility on. Apart from it going through the governance of the subcommittee, we probably need a session, one of our development sessions, where we're actually looking at the finances in that way, both from a current performance point of view, but also the future, a bit what Steve talked about in terms of the commissioning and how we're spending the money and where it's going and right out of place. So I think I hear you, we need more opportunity for discussion actually rather than the subcommittee, because things are complex, they're difficult, and it needs a bit more, I think, airing than perhaps we've. But maybe you have a
reason why we are where we are is in those four parts of consequences of long-standing structural challenges. The report also clearly highlights that we are moving beyond our needs and our space growing beyond which we can afford. And that means we need to focus on our workforce. The vast majority of our income is spent on pay. What's interesting, isn't it, when you look at individual organisations, so it's one that stands out because it seems to have a very grip on its payroll costs, and that is Berkshire Healthcare. And I think we do need to learn from that organisation. I know that Julian Emmons, as the Chief Executive, is very keen to play a greater role in our systems leadership in the workforce space, which I think would be very welcome. Because moving forward, we have to get a greater grip on our pay costs. And we've seen a significant increase in our pay costs since 2019, in the region of 20% increase. And that is just not affordable. So this is an area which we have to really focus on, and has to be front and centre of our approach to recovery.
Thank you, Nick. I also note that Berkshire had one of the best staff survey results. I don't know if you saw them.
The best.
The best in the country. So there's something to be said about, that's the way they engage their staff, the staff that they have. So as you say, some things to learn. And that's a nugget of hope. And we also have had a fantastic result, Steve, from RBHT as well. So we have some high performing individual providers in this place. This is about taking those good performances and learning, as you say, share them. So, Tim, you've got a last one.
Yeah, I've got 5 quick things. I'm not going to go into detail very quickly. The first one is just next away. We should all recognise there are some fundamental underlying issues in the numbers that are very difficult to change, and they're not unique to us. So, pharmacy costs, so medicine costs, CHC, these are national challenges across the board. We have dedicated teams working on them both and have been for the whole time the ICT has been in existence, both of which are doing a very good job. And we've been a lot worse at the situation if they haven't been doing that work. So we're not burying our head in the sands or unaware of some of those big issues, and they're not unique to us. And that doesn't mean they're not important, but nevertheless, it's not everyone's aware of. And less positively, perhaps, there's two other things to pick up. One is about communication and collaboration across the system. I think the teams, it's getting better, is the good news. But I think within the visibility, it links into the third point, which is about forecasting. I'm not 100% confident that we are really, and Matthew alluded to it as well, that the system, I'm not talking about the ICB per se, the overall system, that we are forecasting accurately enough. The example I always cite, which people have heard me talk about, the council as an example. It's not from there these numbers, but it typifies an issue. And so I think we do have to all work hard in the coming year, in the plans of the year, studying about how we communicate, how we collaborate. There seem to be a few, perhaps too many last minute surprises, which is not great. Before point is the balance of the year, and this is month 10's report. Obviously, it's 12-month year, and I think we just need to be aware that there's some other challenges that I think are coming up in months 11 and 12. So I don't think we should feel certainly definitely out of the woods, and there's other potential bumps in the road. So I just think we should be cognizant of that, and we've got a couple of months still to go in the numbers. And then last but by no means least is next year. I think it is worth saying that as much as we are not in a great place, I don't think NHS England, and let's go further than that, the Department of Health and Social Care have covered themselves in glory with the fact that we are not, and we're absolutely not alone in this, we're not getting the guidance when we should be getting it. It's frankly not good enough. And I'd be happy to express that to anybody who wants to listen in the hierarchy. And I think the teams have given their top hand tied behind their back, and that's not only at the ICS level, ICB level, in other trusts. To be given or not given our planning guidance till the middle of March or the end of March is frankly not good enough, and it needs to be said. So I'm saying it. And I also think we need to be realistic as a system about the numbers moving forward in the planning process that we're no doubt dealing with in the next couple of months. I know they're both Matthew from the team who work very hard on. It's difficult, and we've got to be careful that our plans that we've heard a lot about today, which are very exciting and ambitious, are deliverable, and we make difficult choices. I think the transformation board that Nick's talking about is an excellent development. I've got really high hopes for it, but it's going to have to make some very, very difficult decisions, and we have to be brave enough to A, support that team when they come up with them, and B, communicating them back into the system, be that a region or nationally, because there's going to be some very, very difficult conversations.
So good. You want to
Come on, external controls, because I think that's important, and clearly individual organisations sort of operate their own level of control. What we've said back to NHS is that we need to operate, or at least that we will be seeking everybody across the system to be operating as if they were not full. We've had correspondence what we put to correspondence, that conversation in the early part of the year when we were getting on plan, I think the level of assurance that we got back was there at the time, but I think was needs to be sort of upped. So that's to answer your question.
That's fine. You don't want surprises. It would usually illustrate a lack of grip at whatever place, at whatever level. And it just doesn't feel as if that's fully in place yet, or fully mature, let's say, as a system. So that's what we will be used to develop that with the providers and with everyone in the system, quite frankly. So yeah, lots of work to be done. But thank you, Matthew. And I suppose in a way we go on to the risk report. So maybe that's the right segment.
Thank you everyone. So the report is obviously the regular reporting which we provide you with an overview of all of the board assurance framework strategic and what are the currently still the regulated board assurance framework and corporate listed with. This in line with the conversation we've been having at today's board meeting, not providing that they are allowed financial sustainability and ability of access to services. Neither of those have shown any movement in that residual rating over the 1st of September, which we referred back to, which again is indicative of the service offices we have been working in. And I think, as I said before, what we should be using Whisper is to guide where we're putting our focus, and we have demonstrated that through the areas we have focused on in today's discussion at the board. The last discussion at the audit committee, which states that they will review our basis, has highlighted the things which we put in the report that will make improve our reporting and increase the impact of our risk management within the organisation. And the final point I wanted to make is maybe we've got a risk appetite discussion in our board workshop this afternoon, and again that will guide the way in which we report and lead with going. Then I'll take any questions.
Any questions or comments in terms of the practice report? Moving on then, the board assurance committee updates. So we're just asking the chair of each subcommittee to give a short update on the position, please, and what went through their committee.
Yeah, thank you. So it's been highlighted, we're in a difficult time. So some of the areas that we looked at, I think, were quite pertinent. So one of them was, for example, CHC, where we heard that there's a level of sign-off that we think could be tightened. So there's more scrutiny on, say, if there was a 5K sign-off, but it's for many years, that suddenly becomes a large sum of money, which perhaps isn't currently having the level of executive sign-off that would be appropriate. So that was one of the recommendations that we'd like to see taken up by management. Also, for example, there was an accounting change that was done in one part of this, one of the CCB when we came together on the medical equipment, and that is subject to audit to sign off. So that's 6 million. I think that's quite relevant. But if it's not agreed to, then there is a risk there. I think on the positives, there were two substantial opinions that we had, both on population health management and governance, and then two partial on place to transformation, which I think show areas of opportunity to improve on. I think in the interest of time, I'll keep it at that. But I think on the whole, audit continues to, the audit risk committee continues to see areas of opportunity that we can get great assurance from working across our different committees. And that's one of the recommendations that we will rotate around the committees and invite other committee chairs to also take a bit of this.
Exactly. Moving on to place and system development.
Yeah, thanks, Chair. Again, so the reports that's read, in keeping with the theme, just to note a point on delegated special commission, within our financial situation at the moment, raised this as an area of concern. I think in relation to Oxfordshire specifically, but I think it relates to other places too. The only other thing really to raise, Chair, is the terms of reference were subject to that discussion at the last meeting. I think it's kind of obviously part of broader governance review, something that we want to really strengthen there as an opportunity to reach deeper into places and to be able to kind of pull out more practical data and insights really into what's happening at a community level. So it's something that I hope to be able to bring back to the board in the not too distant future, but it does feel like a time of transition for this committee, in a positive sense towards reaching more of this attention.
Yeah, and then moving on to population health, Margaret.
I was absent, so thank you.
Oh, it's beautiful. I was chairing that meeting. Yes, in your absence. Sorry. Yes. So we just brought up an emerging risk, and that was around the demand for ADHD. So I think we all were cognizant of that, but we felt it was important to sort of note that, if you like. And then the other area of note, and just that we thought was important to bring up, was this role of the physician associates. So assistants, I think they're associates or assistants. Associates. So this is a correction, I think. So associates. With particular focus on the Royal Bar. So I think there's a lack of understanding, a clear understanding about their role within each of their settings, because I know physician associates are within primary care, they're also at acute trust level, are they not? So what they do and how they deliver their product under the aegis of a particular senior medic is really important to the public, because I think there's a lot of and misinformation. So I think we've got to take heed and make sure we get better at communicating what they do, how many we have in the system, how they serve and what they do, and basically the positive impact that has really occurred in each setting. So I think that's the most important thing. But I think Amy made a point. I think most of the subcommittees are evolving in a positive way as we attend further to prevention, population health and place. I think that deepness and that richness of the conversation will continue. So all chairs are committed to making sure that their agendas are appropriate and the discussions are as well. Thank you, Margaret. Moving on to Tim, system productivity.
Thanks, Sim. Yeah, I won't go over the finance part again because we've already discussed it. But obviously there's significant discussion and probing around that. Similarly, you touched on already the operating plan and the forward guidance, both in terms of operations metrics, which were generally pretty positive, with the exception that we made currently is projected. There's a challenge over the 4-hour wait time for A&E. There was concern, as I mentioned earlier, about the assumptions that were made are going to have to be made in the coming year. The other thing we talked about, Matty gave us a good presentation and discussion around the acute provider collaborative, about how it's good that it's being formed, but there's a sense that it can do a lot more, and it needs to be supported and challenged a little bit more. So it certainly wasn't a negative view, but it was a how do we make this do more for the system? And I think a lot of what Hannah's talked about already is going to be predicated on that collaborative, really motivating for us. On the advice side, the AMBO side, there was some good update on cyber risk. There's a slight concern over some patching of older systems. Tori and the team able to give us some assurance, which was good, but definitely we need to not just rely on patching, I think was the broader point. General system priorities, again, the team, we've got a really good plan and it's been well managed. In terms of the cost and the scope, that's good, but the actual progress, it seems to be not quite where it needs to be on all the projects. A lot of those projects, if these are system projects, very few of them sit within the ICB on its own. They're collaborative events, but we need to delve a little deeper and support the system partners on that. The IECG, which is this efficiencies collaboration group, is now going to be subsumed into Hannah's world. But the good news is that everyone involved in it is very positive about it. And I think the impression we get is that the providers see its merit, and hopefully as it morphs into Hannah's world, will become a very important delivery mechanism for improvement and transformation that we've talked about already today. So that was, again, going well, but needs to do better, hence the amber. And then we've got two good green report, one on the day-to-day IT performance, which remains pretty robust. And also, in terms of our annual reports, we seem to do okay. But we, again, must not be resting on any laurels, particularly given our financial performance.
Thank you, Tim. And then lastly, from the People Committee. So the ICB People Committee, we relaunched it, if you like. So this was the first meeting of the renewed ICB People Committee because it was felt important that during the change programme, there was scrutiny and there was a review and exploration of the way that was being handled and how our staff received that. But also, given the staff surveys, it's also felt that we needed to concentrate on our own teams and our own people. So the re-established committee might be time limited. It depends on where we go with the change programme and how we do our staff survey results as we go on and pulse surveys. But basically, we need greater assurance that the executive have the help they need and that we're able to help our people. So we're going to review and scope after a year and see where we are. But I think the committee members, you can see two layers, chief executive officer, I won't go through that. But basically what we'd like is approval from the board. I'm hoping you're able to read the terms of reference for the people committee. If you could just, if I could have some nods about its scope and its remit, very clear, very tight. But the role of responsibilities going to be, that would be helpful to us, and then we can adopt that and take that. I've got nods for the mentions for April here. Thank you very much for that. And then the only other thing to say is that I'm very pleased about the freedom to speak at work. That's been a long time coming. I'd like to thank Catherine for pushing that and aiming to take the task of being non-executive leaders in that area. And hopefully we'll submit your forms in terms of different persons process. And we will continue to, we're looking at the appraisal process and embedding EDI metrics, system metrics into those non-exec directors and with executives. So thank you. That concludes all of the subcommittees.
Yeah, just pick up on something that Tim said. I know you didn't mean this, but just to ensure that no one infers that the whole recovery approach sits with one executive. This has to be a joint endeavour. It has to be owned by the entire executive team. And similarly, the approach to ensuring that we can put our system on a sustainable footing in the medium to long term has to be owned by the entire system and all parts of the system.
Thank you for time. So Hannah, you're not solely responsible. So somebody responsible for that.
I'm going to work related to the people committee, just to say worth noting that I was very impressed with Caroline and Sandra who presented at that committee in terms of they've got a lot on their plate at the moment and they're both obviously new to the organisation, but I thought I was very impressed with how much they work on top of their brief and also their plans going forward. I thought were very impressive.
I think that completes the subcommittees, and then just the forward plan. Anything to mention on the forward plan? Any comments, actually?
I mean, yeah, it's to take comment. We've obviously now got a forward plan for the whole of the next financial year, and probably some work to do in terms of refining it and thinking about how we report on progress on delivery against our sort of border operational plan and look at the system goals. We've got my friends to do some different parts. But keep the same structure we've had for the last 6 months and comments and commissions into the wrong place. That's a lot of no.
Okay, I think the discussion we've had today is we'll just review this in terms of the operational plan, please, and the system goals, and just making sure there's time for this board to, not to be presented with something to sign off before we've been through some more detail. This feeling of pressure. I think that's what we're running. So as long as that represents that, if we please go through the final. Any other comments, colleagues? No. In that case, any other business? Anybody want to read anything else? If we happen to pass, Okay, thank you very much. I will close this meeting. Thank you very much and see you this afternoon.